Again, reminding members that the meetings are held in public session, so please switch off mobile phones and Blackberries. I've had no apologies recorded. No other apologies, so. Okay, and a few items just under Chairperson's business briefly. I want to advise members that the motion on the review of supported living for older people has been scheduled now for the 13th of October. I also want to advise members that myself and the clerk attended an event organised yesterday by the department, which involved a presentation from Professor Alexis Jay, who undertook the inquiry into child sexual exploitation in Rotherham. It was quite a stark piece of work and a stark report. I think the key message that was coming from Professor Jay's comments was about the collective failures in the system that had let tens of hundreds of children and young people down, and I suppose the need for ourselves to learn the lessons coming from that, particularly in light, I think, of the conversations and discussions that are ongoing around the quorum of the Safeguarding Board. Professor Jay briefed the audience, obviously, on the findings of her report. I'm just advising members that by way of follow-up, the evidence session with the department regarding the Safeguarding Board and the thematic review of child sexual exploitation cases is now scheduled for the 15th of October, if members could note that date. I also, under Chair's business, want to raise the issue that has been to the front of the local media in the last number of days around the potential crisis in cancer services, and suggesting that the committee extends an invite to Dr Martin Eatock, the consultant medical oncologist at Belfast City Hospital, and to Professor Joe O'Sullivan from the Cancer Centre at Queen's, given that they specifically have highlighted concerns around the potential impact on cancer services and what may be coming down the road at us. I'm suggesting that we would invite them to the committee to give us an evidence session around those issues and their recommendations. Can I have agreement to do that?
Agreed.
Agreed. Also, I just want to welcome Paula Bradley. I know this is your first meeting as the new Deputy Chair, Paula, and Paula's interests are on the table in front of people, and can I just say I look forward to working alongside you, Paula, on the committee duties. You're very welcome. Item 3 is the draft minutes of the meeting from the 24th of September. They're on page 5. Can I ask our members' content?
Chair, there's just one, just for information. It was in relation to the letter from the Children's Commissioner on the clause 12 of the new bill. It says in the minutes that we noted it. Is the committee not going to discuss support or otherwise for that? Clause 12, that was about separated children.
Yeah, I think the committee did note it, you're right, last week, and my understanding, Kieran, is that Justice were considering it last week. So if we maybe want to get an update from Justice in the first instance, I'm happy to return to it then.
Yeah. Okay, thank you.
Okay, thank you, Kieran, for that. Item 4, members, is the October monitoring round. I want to refer members to page 10 of the meeting folder and page 3 of your tabled folders for the relevant papers. Again, reminding members that we requested that the Minister attend today's meeting to discuss the Department's October monitoring round. The Minister has written to the committee advising that due to the short notice and the short time that short time that he has been in post and the number of challenging issues that he needs to work through and address, that he will not attend the meeting today. I have to say, I think given the nature of the particular scenario that we're looking at in and around budgetary constraints and indeed the timeline around the October monitoring to be submitted tomorrow, I think it's unusual that the Minister didn't or couldn't attend today.
Yeah, Chair, I would agree with you. I mean, the Minister is well aware. He's been on the Health Committee for a number of years, and he would be well aware of our concerns. And I am disappointed, I must say. I understand he's only in post, but it's, as you say, it's a very pressing job, and there's a lot of stuff that needs to be tackled, and we have, and we're delighted to see Catherine and Julie back. You're a stranger, sir. I think it's the third time in a row that you're here. You're very welcome, of course, but it would have been nice to see the boss here along with them to get a further feel for the anxiety that members have in relation to all of health concerns.
Okay. Okay, any other comments on that? We will come back to this on the back of the evidence that we hear today. I just want to then obviously advise members and welcome the officials that are here today on the October monitoring round. Julie Thompson, you're very welcome. Catherine Daly and Bill Polly, very welcome to the committee. So I'm just going to hand over to yourselves, and then I'll open it up to comments or questions from members.
Okay, thank you, Chair, for the opportunity to provide evidence to the committee today on the Department's proposed approach to both current expenditure and capital investment expenditure for the October monitoring round. Since our attendance at the committee last week, we have had the opportunity to discuss the proposed approach with Minister Wells, including the nature, scale and scope of bids to be submitted and their prioritisation. In terms of current expenditure, we have considered a range of factors, the most significant of which is the financial context for 14-15. As outlined in the briefing paper and as we discussed last week, members will be aware that after June monitoring, the Department faced a deficit of £140 million to manage in 2014-15. Given the uncertainty in the financial position, we have already been taking steps to constrain some expenditure where it is possible to do so, and hence manage an element of the unfunded pressures internally. Unfortunately, this is having a detrimental impact on performance, most notably in waiting times. We are also aware of pressures out with the Department, and that is, for example, within some community and voluntary bodies and the use of the independent sector in terms of the services that they provide to the HSC. Notwithstanding the impact on performance, from a financial perspective, these constraints on expenditure and delays in making commitments have meant that the unfunded pressures have reduced by some £10 million. This means that bids of £130 million are being submitted in the October monitoring round. In overall terms, the bids are based on those areas of unfunded and uncommitted expenditure that were highlighted in the previous Minister's letter of the 28th of August, and are therefore directed towards delivering a range of critical frontline health and social care services. For example, there are substantial bids in relation to unscheduled care and patient flow issues, which would mean that trusts would not need to reduce agency and locum doctors or agency and bank staff or domiciliary care packages as is currently proposed in their contingency plans, and that they could make the necessary planned investments in ED capacity and measures to improve patient flow. Bids are also being made in a number of other areas such as elective care, specialist services such as drugs, cath labs and cancer, as well as a range of public health initiatives, mental health and learning disability resettlements and pay awards. We are bidding for TYC transitional funding to enable progress in the implementation of transformation, and we have prioritised the bids in line with DAP requirements. Turning to capital expenditure, as we outlined last week, the key constraint is that any bids must be for projects that can be fully spent in 14-15. Our approach to capital is namely that two bids would be submitted. The first is for an additional £12 million to provide additional resources to buy medical and other equipment, address minor works, improve the clinical environment, improve vehicle transport and address ICT needs. And the second is to retain and use the €3 million from the Republic of Ireland as part of their contribution to the Alton Galvin radiotherapy project. In conclusion, all of our proposed bids will help to mitigate the detrimental impact on frontline health and social care services. However, given the serious challenges facing the Department and the late stage in the financial year, decisions are very urgently needed on the additional resources to be made available if the worst of the consequences are to be avoided. We would therefore strongly recommend that the Department's bids are considered favourably by the committee, and we are of course happy to take questions from members.
Thank you, and thank you, Julie, for that. Nice to say it's a very different bid. I think that is the position. It is a very different bid.
The format has changed, but the actual figure work behind it is substantially the same.
Okay, well, the paper states now today that the October monitoring round, as you've outlined yourself, the Department intends to bid for £130 million. That was compared to the previous June monitoring round of 160. What are the key differences?
In terms of the differences, at the start of the year, we're looking at the range of pressures that were likely to appear across the year as we looked forward. What we've done now in terms of making the October monitoring bids is, and as the committee is aware, we have looked to see where expenditure could effectively be stopped or curtailed or brought back or limited in some way through delaying service developments or implementing contingency plans. We have therefore framed the bids around effectively those options which were set out by the previous Minister at the end of August. And the figure work is effectively substantially the same. We have, yes, taken some measures in terms of managing those pressures ourselves. Equally, there's also been a realistic assessment of what can be spent between now and the financial year end. So the actual work around it is exactly the same, and the difference in style is more about the fact that this is now looking at what effectively is expected to be spent between now and the end of the year, and that's the money that we need in order to sustain those services. If we don't receive the money, then the service developments have to be stopped, or the contingency plan measures have to be put in place. When we did it at the start of the year, we were looking at the pressures as they were presenting across the entire year. You will see, though, there's an awful lot of similarity in terms of where the bids fall. Unscheduled care was there before, elective care. There's a large degree of similarity in terms of the areas we're focusing on, but the bids at the moment are positioned around how and where expenditure could effectively be stopped between now and the end of the year, and that's what we need the money to bridge.
Well, I think there's also quite a lot of differences, particularly in relation to policy focus, and I think we can get into that, where the priorities are. But, you know, have you taken decisions about what not to bid for?
In terms of where the bids are, they are focused, as I say, around the uncommitted expenditure. That's the emphasis of the October monitoring bids. They are where it's not about strategic prioritisation. It's literally about where money could be stopped. And it comes from all the work that was done around uncommitted funds, and therefore where effectively you could either provide additional money. If that money is not provided, then the service development can't happen, and that's obviously going to have consequences in terms of what will happen on the ground for patients and clients. So the figure work within the bids are all about the actual level of spend that could be stopped between now and the end of the year, and bidding effectively for that money to allow those services to continue.
Okay, I just find it strange that a bidding process wouldn't be about strategic prioritisation.
It's the reality of where we are in the financial year. With 140 million of pressures presenting, we've had to look at the options about what can be done about that. The reality is, as the previous Minister described to the committee at the beginning of September, the reality of this is you wouldn't want any of this to happen, and this is all about ensuring that we have the resources we need to put those services on the ground. If we don't get the money, the services cannot go on the ground, and that will have severe and challenging consequences for the patients and clients in Northern Ireland.
Yeah, but I think I want to move on to something in terms of strategic prioritisation, because I think that's critically important. And obviously, and again, this is a point that I've made a number of times with yourselves, there should be a priority list. There should be a strategic priority list in terms of what the priorities are going forward, which leads me on to the whole issue about transforming your care. And you know, this was the great hope, if you like, in terms of the delivery of our new health service and the shift left from acute to community primary, all of that. So in June we had a bid for transitional funding for 21 million, and it was category C, which the committee had challenged, and rightly in my view at that stage. In October the bid is 2.6 million. And it has been moved to category B. What's the rationale for that?
If I can, Catherine can pick up the specifics in TYC. I think the issue is that what we have had to look at now is about where spend has not been incurred. So the additionality that could go into TYC between now and the end of the year is 2.6 million. That applies to every other category of bid within the list. The things that are at the top of the list now are, as we explained last week, around protecting patient flow, around ensuring that the hospitals can manage through the winter, about ensuring frontline services are protected, and that the actual contingency plans the Trust came up with would not actually be implemented, and because of the damage that those proposals would actually do. Those are the things that are coming to the top of the list as, this time. TYC, as you say, then is in the second order category because it is something that we most definitely would want to do. And the difference in the numbers is because of the change in the way the bids have been put together. 21.3 was the amount of money effectively through the year. Through to this point, money has already continued to be spent on TYC, and therefore this bid reflects the remainder of the spend between now and the end of the financial year.
But, you know, with respect, Julie, you've just outlined to me the strategic priorities that TYC is. But 5 minutes ago you told me this isn't based on strategic priorities. This is based on technical issues. I mean, which is it?
In terms of how they've been prioritised within the actual bids that are there, they have been given a strategic prioritisation in terms of the A and the B and the C. What I'm saying is that in terms of whether you would do these things or not, they have come from a list of uncommitted funds. These are not the things that would come to the top of the list if you had free rein to say, right, these are the things that I would like to stop. It simply is a matter of fact about the things that you could stop. If people are in employment and if they are already effectively employed, that you cannot stop that expenditure. That expenditure will continue. These bids are therefore around the elements that you can actually stop and that there is discretion about. In that sense, they're not strategic. They simply happen to be a strategic. A look at what is actually uncommitted at this stage and therefore the options that are actually available. Once we've looked at that, we've absolutely then tried to give them a ranking which respects the primacy of patient flow and safety and quality of services for patients.
But I think, again, people looking at this would say TYC, the main plank to actually provide some of the outcomes that a lot of these pieces of work are attempting to do. And, you know, we have 21 million bid for in June, with TYC listed category C. We have it upgraded now to category B, and only 2.6 million.
Which reflects the level of spend that is able to be spent between now and the end of the financial year. This bid is all about what can be spent between now and the end of the financial year and where we need additional resources to enable that to happen. That's the difference in terms of the 21 million, which was viewed as the expenditure through the year.
Maybe could I pick up on that, Chair? Just come back to the figures in June monitoring of 21.3, and I think it's probably been confusing just the approach we've had to take because of the funding that wasn't secured. There was 21.3 was bid for in relation to TYC, and when we looked at what was not committed, then we had a figure, but there was within that 21 there was already 12 million expenditure was committed and being implemented on the ground. So that actually is currently taking place. As Julie said, in terms of what we're bidding for now, in moving forward, we had to look at, given the extent of pressures we're dealing with, where there was funding, not that you would want to stop, but simply that you were able to stop. And so an element of TYC came into that. But with as time has moved on, some of it, there are some elements of that as we get into October now, well into halfway through the financial year, there's some things, excuse me, that it wouldn't be possible to do. And the elements that are identified here under the 2.6, these are actually quite critical. I think the case has been made very clear in terms of the benefits, but even with these, even now, timing is critical around this, because even for the atrial fibrillation expenditure of 1.5 million, the ICPs, the board, the GPs are telling us it's critical to have that money now in order to run with flu clinics. And these are the sorts of things that, you know, if timing runs against us on that, and we miss the flu clinics, then it's not possible to spend that money in the way that was intended. And that's basically what's happening as time progresses.
Okay, I know Roy wanted in on this point.
Very briefly, I understand the local commissioning groups have come up with some strong business cases for adopting new models, and have been collaborative working. All the professionals have come together and agreed new methods, and yet it doesn't seem to be funded. Are we in danger of demotivating those people and preventing the new methods of working which bring about that saving, so we don't have to amputate limbs, that the earlier intervention will result in less people having to face that. So has all that been taken out, and are you at risk of these local commissioning groups falling apart because we're not funding them?
Well, this is something that's absolutely at the forefront of our thinking in terms of the whole transformation programme. It is important to keep up that momentum. Now, within the bid here, there is £1 million that's being sought to enable equity of clinical priority pathways, and that is some of the work I think you're talking about there. That has already been implemented in the Southern and the Western Trusts, and the purpose of this bid is to enable that to be taken forward in the other three trusts, so that not least you have equity of access and provision across Northern Ireland. But the sorts of things that is, there are a number of pilots and education programmes that be established, and that includes expenditure on falls prevention pilot, patient education on diabetes, stroke and early supported discharge programme, and education for GPs in the treatment of chronic obstructive pulmonary disease. So there's a whole raft of things. Those are things that if we were able to secure the funding now, could actually be delivered, and so that would help to build momentum. In terms of the bid that came through in June and what hasn't been secured on that still needs, in terms of the transformation, to be delivered, and that was something we need to look at moving forward.
It just strikes me that some very common sense areas which would be better for the patients, better for the health service, are not being implemented.
Okay, thank you, Roy. And it's on a similar vein, the issue about the bid for public health. Again, it was 10.5 million in June, and it was priority A. And I think again, along a similar vein, where we look at a shifting from acute to community, primary, interventionist work, all of that. In October, this bid that's in front of us today is for 3.5 million.
Yes,
Why the
and
shift?
again, it reflects the spend that has continued to be incurred since the original bid in June was made. So the bid that is outstanding that hasn't been invested at the moment is 3.5 million, and that's the element that we are bidding for. So expenditure has continued to happen through the period between June and October, and that's why the numbers effectively have been changed to reflect what has already been incurred. So we're not bidding for what's been already incurred. We're bidding for the amount of money that is expected to be incurred between now and the end of the year, where we wish to put public health services on the ground.
But then is that out of the 20 million that you were allocated?
In terms of the 20 million, as we discussed, we haven't actually got it yet, and we're not bidding.
Then how can you say this is for money? Sorry, Julie, but how can you say, that's an answer to both those questions? You've said there's been money incurred in these areas. This is what's left, almost, that we have to bid for to reach it. So how do we know what's left if you're not telling us what to spend or intend to spend the 20 million on? And it just seems to me again that the shift in terms of the policy focus of this has moved. Because public health is now shifted from priority A to priority B.
In terms of where we are at, those are two slightly different issues, and I'll deal with the prioritisation one in a second. In terms of the difference in the bids, a large portion of the original bid of £10 million in June was to do the vaccination programmes. Those vaccination programmes have happened and are happening and had to be committed to as we work forward. So that spend is happening as we speak. The bit that hasn't happened is the 3.5 million, and we are focusing these particular bids on where we haven't got the money effectively to continue the investment that was already there. We will come back to where the 20 million effectively gets spent. What we have done and how we know is because we've done an entire review of all of what is not committed to date, and therefore where we still need additional resources to allow those things to happen. And the prioritisation that is in play is effectively to say patient safety comes absolutely first priority, patient flow comes first priority, and much as we would love public health and TYC and everything else to all be at the top of the pile, they can't all be at the top of the pile. So we are trying to give some sense of prioritisation to it. In reality, what you would have, depending on what money, if we get additional resources, you would then look across the entire patch. And it isn't as simple as to say you draw the line where the funding ends. You would potentially look at funding an element of each of the bids when it comes down to it, and that will ultimately be a decision for the Minister.
Right, I'm just really unclear about this. And what you're saying with the public health bid for 10 million, that you effectively were able to spend 7 million without getting the bid?
And hence why we are short 140 million as we look at it now.
I think
But it was still, but you were still short
Yes.
in June.
And we are still 140 short in June. And what we've done in terms of the bids is identify all the areas up to so the gap that we've got is 140 million, and we've identified the areas that you could effectively look at to control, to manage, to reduce expenditure, and those are the things that that we're bidding for, because they're in reality the only things you can do to break even. You're absolutely right, the vaccination programmes have proceeded. And that's one example of why we're 140 million short. Those vaccination programmes are ongoing, and they're actually working through as we speak. It's not those that are a focus of the bid, because the spend isn't being incurred, and the commitments are already made. The bid is about where we haven't made commitments and where we can therefore reduce and control expenditure.
Okay, but in the context of this then, in terms of the whole public health agenda and the priority that was given to spending money to prevent ill health and to target health inequalities, where does that leave that agenda?
It leaves it needing another 3.5 million to deliver what it wanted to deliver within 14-15. If we get additional finance, whatever that scale may be, the Minister will then need to decide where that additional funding goes, and whatever is not able to be financed will have to be delayed or stopped. And that applies to every single bid right the way down the list, because it is looking at where the options are available in order to control and manage spend between now and the end of the year. If the money doesn't come, then everything on this list effectively stops in terms of service developments, or needs to be implemented in terms of contingency plans and pay restraint.
Okay, and I know there's a number of members who want to come in on this, but specifically one of the other issues is a bid for pay awards for 15 million. So this doesn't or didn't appear in June. Has there been a need for this money to suddenly emerge?
Again, sorry, Catherine talked about the date of the pay restraint. It's exactly the same issue, whereby we had a pressure of 160 million. We'd looked across the piece about where bids would be put in place in June. We came out of the back of that June monitoring round with a promise of 20 million, which we haven't received as of yet. We therefore have had to look, given the stage of the year, at what are the options to actually break even. And one of those options is to not implement the pay reward that we would otherwise have done, and Catherine can certainly take you through the detail of that. Hence why, if we get the funding, that pay award can go forward. If we don't get the funding, or we don't get enough funding, the Minister will need to establish what his priorities are.
So why does it not appear in June?
Because in June we were looking at the list of the whole pressures across the entire system, and those were identified at that point. This is a list about uncommitted funds, and therefore where we need to actually take decisions, or where decisions would need to happen post-October monitoring to identify what would change or what would have to be stopped.
Maybe if I could pick up on that, Chair, and maybe this is an example just to explain that difference between June and October. In June, the bids were put forward in terms of all the pressures across the department. To say when we didn't get the funding, then we had to look across the budget to say what can actually be stopped. Within the overall budget figures, provision had been made for potential for a pay award. An element of that would not have been committed. When we look at pay, there are elements of pay which are contractual obligations, and elements which then are discretionary at the discretion of the Minister. So in looking at what was in the baseline, we have looked at what would be required to deliver on contractual obligations and maintain relevant pay policies, and that actually would then highlight that against all of that there's 14.9 million which is not currently committed under contract or under any agreement, and that could be used to offset other pressures. And that is why I think the Minister has been clear in saying these are not the things he would want to do, they're simply the things that could be done.
But if we're talking in terms of this document in front of us being uncommitted pressures, And bids are supposed to be about major or unforeseen circumstances. Do you agree that these are major and unforeseen circumstances?
Absolutely.
That what's in front of us today are major and unforeseen?
In terms of, it's the entire 140 million, which is major and unforeseen, and that is driving the bids in front of you. What we are bidding for, as has the previous minister already given to the Executive and to Health Committee, is being very clear. These are the options. Either funding is provided for these things to happen, and that will allow them to happen, or they will all have to be stopped. So it's the drive of the 140 million, which is major and unforeseen, and he's looked, and we have looked right across the budget to identify, well, what are the options there? That's what's been put to the executive table and will be put to the executive table. Either these money is provided to back these proposals to go ahead, or they will all stop.
Well, it's 130 million now. I know Fergal wants in on this, but just a wee quick comment on this, right? Fergal, just before I bring you in, just one comment on this as well, because it's related. The issue about the pay rise, there's also reference to bidding for money for 8 new clinical excellence awards. I mean, really? This has been subject to much debate around the 34 million to senior consultants for bonuses. This process was to be frozen.
Okay, can I pick up on that, Chair? Yes, the Clinical Excellence Awards were frozen for 2 years during the pay freeze, when pay was frozen, because Clinical Excellence Awards are deemed to be part of pay. It's also been recognised that in terms of recruitment and attracting the appropriate calibre people, that there is an important element. But in terms of what's been going forward, this is a reduced number of Clinical Excellence Awards, and there has been money freed up from within that budget as a result of that. But again, these are, under current circumstances, they can't be met. But it's a much reduced. This is the higher Clinical Excellence Awards only, and it's a much reduced number.
That doesn't make it sound any better, I have to say. I mean, it says in this that it's bidding for money for 8 new Clinical Excellence Awards. And again, I would suggest to you, at a time when there are major pressures on our frontline services, and I don't need to repeat all of that's going on in our emergency departments. We have the senior top tier of the system, a bid for additional money, and it doesn't assist in terms of the agenda to actually eradicate some of those difficulties and to actually deal properly with health inequalities. Fergal, you wanted in on this?
I'll tell you what, Chair, I'll leave it just until I come back to my own questions, so just for the moment.
And there's a number of people I want to bring in. Kieran first.
Yeah, Chair, thanks very much. Again, thanks for being here. Disappointed the Minister's not here. But again, go back to that 20 million, Julie, that you were last week you were here and you said that you hadn't got that, and you still haven't got it. Well, I mean, if it's going to take you that long to get 20 million, a mere 20 million at 160 million, it's going to be a hell of a long time before you get the 160 million, and you don't even know what to spend it on. When you get it, what's going on? What is going on? 20 million, and you're desperate for 160 million, you haven't got it, and so the problem goes on.
The 20 million, as I understand it, will be confirmed through the October monitoring process. That's the process that we're working through at the moment. In terms of decisions on that, all the material from departments is to be submitted tomorrow, and then it will pass through DFP and into the executive from there. And absolutely, you're right, we need very, very urgent decisions about how much additional resources the department will get, and then moving from there into where the money will be allocated, because without it, expend continues, and we also then don't know exactly what we can deliver through the remainder of the year.
I hear what you say, but you have been given 20 million out of the June monitoring round, and that was, I think, at the end of August.
It's conditional, we haven't received it yet. It will only be...
Conditional on what?
Conditional on ensuring that steps are taken in order to break even, and we are discussing the very issue about that, which is, can we break even as we speak? So it's part of the decision-making process around October monitoring.
Right, okay. I mean, you mentioned, I think it was in a response to the Chair, that hospitals, a lot of this funding is dependent on managing through the winter. That was my. I mean, you can't even manage through the summer. We're still in the summer, and as the chair has said, I think it was the Royal was in difficulties with A&E, and the Ulster had to close. I understand it, and certainly direct patients away from the Ulster. And this is still the summer, and you're talking about managing for the winter. It's not going to happen. The patients are going to suffer, and perhaps even worse.
Well, I mean, if I can pick up on that one, there are, as you see, within this bids for unscheduled care, and I absolutely note your points about the level of activity and performance during the summer months. There have been issues at the Belfast Trust in relation to 12-hour breaches, and that's something.
And they also this week too. They closed completely. No admissions. Directing patients to wherever they could go to. That is disgraceful, surely.
Well, that is something which certainly is a very high priority for the department. And I mentioned to the committee last week that there is a task group which has been established and is chaired by the Chief Medical Officer and the Chief Nursing Officer, which are specifically looking at the issues around this. And the objective there is to ensure the elimination of all avoidable 12-hour breaches by early November, and to have a significant improvement on progress on the delivery against the 4-hour target, because again that is not where it should be. And I absolutely take your point about where things are, but this funding is critical in order to take forward to address the pressures that we know that the Trust will face in the winter months, and actually to fund some of the areas that will actually lead to that throughput and patient flow, to ensure that there is effective flow of patients through the hospital, and also effective discharge. And you see that within that bid there are a number of elements of that, and they're all linked. So you know, I absolutely understand what you're saying in terms of where things are, and that's why this is absolutely critical. The funding's needed to address this.
So the future is bleak, really bleak, if this funding, these bids are not met.
I couldn't say it wouldn't be. This is actually critical, and it's a critical area.
It's disgraceful. Finally, Madam Chair, on the paper you presented us, the department has managed to find 10 million in savings since you were here last week, as I understand it. How has that 10 million been saved, and what have you chosen not to fund, and why?
In terms of the 10 million, is a combination of looking at right across the budget about where funding could be stopped. We've discussed, obviously, the TYC one, for example, where the numbers have changed. We've looked right across, both within the department and the HSC, and effectively have tried to manage some of those pressures without making the bid into the centre, and that's what the 10 million is a combination of. It's exceptionally complex because obviously you're going right across the budgets, but better to put it a bid at 130 than 140.
Right, okay. I'm getting more confused as we're going on, but I'll leave it till there's.
I just want to pick up on that, because I think it is important. You know, can you give us examples?
In terms of where we've looked at, the clinical excellence one, for example, that Catherine talked about earlier. We've looked at ICT budgets. We've looked at blood transfusion. We've looked at.
But where you found the 10 million, not looked at, found.
Well, that's the examples I'm talking about. TYC has been reduced down. We have looked right across the budget to identify, and the ones that I'm using the wrong word to you in terms of what I'm meaning, but we've looked at how savings could be pulled out of those particular areas, and basically said, look, we would want to have put money into those areas, but we have effectively, because of the financial position, tried to manage some of that internally within the department, and that's what brings the unfunded pressures from 140 to 130. But it's exceptionally complex right across the entire budget.
But again, you know, I'm getting more confused as I'm listening to this. Yeah. You were talking about the TYC bid as being the bid for what was left to be spent. You're after saying there now you actually reduced the bid. Yeah. So which is it?
Well, if I can pick up, because it's actually a combination of both, and the figure in the bid was 21.3 in June. 12 million of that is already committed and on the ground being spent. 2.6 is being bid for here, and that means that in overall terms, the overall pressures would have been reduced by 6 million from TYC because of the fact that it's simply not possible to take forward those elements of expenditure. So that's one element. But as Julie said, there's a whole range of things. But I mean, that's one to take and try and explain it. So it's a combination. It's what the original bid was. It's the element of expenditure that's already committed. It's the further bid that we're bidding for here. But there is an element that can't be taken forward, and that's 6 million. So obviously that contributes to reducing the unfunded pressures.
Okay. Pam, thanks next. Kieran.
Thank you, Chair, and thank you for your presentation today. And I have to say, I don't envy any of your roles. In June, the department bid for 20 million for specialist services. The October bid was 10 million. What was taken out of that bid since June?
Again, it's a reflection of the June bid was the pressure accrued through the whole year. The October bid is based on the amounts of money that we can spend between now and the end of the financial year. So the areas are the same areas. It's just reflecting the tail end effectively between now and the end of the year is why the bid is lower than what it was in June. So it's the uncommitted element of the bid that is remaining within the October monitoring bids.
Okay. And in June, the bid for elective care was 30 million. And it was category C. In October, the bid is 27 million, but it's been moved up to category B. What's the rationale for changing the priority?
Again, I mean, the issues are the same. The expenditure has continued to be incurred. Services haven't stopped. Actions are having to be taken, and I think Julie outlined some of them earlier. But the bid now for the 27 million, that reflects the extent of the backlog and the gap between demand and capacity in the system. The gap as it currently stands for elective care, there's there's a shortfall of 85,000 on outpatient assessments and 25,000 on inpatient and day case treatments, and a lot of that will be funded by the HSCB in relation to additional funding they would provide from within their resources to the trust. But this bid would provide for almost 20,000 outpatient assessments and over 7,000 inpatient and day case treatments. The bid also includes 6 million for diagnostic shortfall, and at the current time, the waiting list for diagnostic testing at the end of July was 14,000. The estimated gap between demand and capacity for diagnostics is around 2,000 for endoscopies and 55,000 for all other diagnostic testing. So this bid at 6 million would enable over 50,000 diagnostic tests to be undertaken. So that would significantly address the shortfall between demand and capacity. So that's, there are new elements in it, but there has continued to be expenditure undertaken. Say there are some areas where there is action the board will be having to be taken, and that will impact on waiting times.
And just to clarify then, if that bid's not met.
Oh, that bit's not met. We're going to have increased waiting times right across in all of those areas, and we already see in elective care that the waiting times have been increasing over the last month. There had been improvement up until March 12, between March 12 and 13. We're seeing increasing waiting times, and there's a whole combination of factors contributing to this, and this is something that the board's looking at. There's the whole the demand capacity issue and that whole gap. That's something the board's very focused on. But the reality is there is a real gap. There is funding needed, and if it's not provided, there will be increases in waiting times without any question.
Very grim outlook. Thank you.
And just the rationale for shifting that priority again from it was in June it was category C and now it's category B. What criteria is applied there to decide
Looking at the prioritisation now, the two that are Category A, as in unscheduled care, patient flow and specialist services, are viewed as the ones that are absolutely critical to maintain the hospital system and keep it working through the winter. The next batch are where absolutely there are service developments that are planned and that we would love to have happen, and that includes the elective care, but if money isn't available, they can be stopped. And the final batch in terms of Category C are about the pay awards, money for pharmacy and cuts to ALBs, and those are viewed as things that, again, one would love, I'm sure the Minister would like to have in place, but the priority has been given to all the ones above it because they are about frontline patient care. So the priority is always about frontline patient care, and the choices are around what is absolutely essential as we look into the winter to keep the hospital system going. As I've already said, depending what level of resources is made available, it isn't just as simple as saying you go down the list to as far as where the money runs out. What the Minister will then do at that point is to look to see what he can do across all of the bids to meet the priorities and work through them in that way. But each individual bid has to be ranked as a totality.
Okay, but was it not absolutely critical last week as well when it was Category C?
In terms of the Category C list, a lot of the expenditure was already on the ground, and we were looking at the pressures right across the system. This list has been prioritised based on uncommitted funds, and that's where the difference is.
Okay, so have we just, and I mean, sorry for interrupting Pam, but are we now saying that we have categorised hospital services over community stroke prevention?
No, because within the
We're not saying
unscheduled
that.
care and patient flow is a significant element to do with domiciliary care, because it is vital that domiciliary care packages are in place to enable that patient flow to work right across the system. So the ones that are Category A are about maintaining the flow through the system so that we don't get blockages and that as far as possible people will flow through. So there's a significant element to do with community care within that unscheduled care and patient flow bid. So it is absolutely not about hospital good, community bad.
Okay, I have a number. Pam, are you finished there? Yeah. Paula, next.
Thank you, Chair. I want to ask you about two bids that have both been put in for the October monitoring round, which weren't originally in the June monitoring round. The first one is 13 million, and it's categorised as other departmental priorities, which in itself is quite vague. Just would want to know, first of all, what are these other departmental priorities? And the second one is a bid for 18 million, which I think is for pharmacy, that didn't feature in June either. Can you tell me where that's come from?
Yeah, in terms of the other departmental priorities, it is made up of a range of areas, and I appreciate the title maybe doesn't help to convey that. We have effectively uncommitted funds around grants to voluntary bodies, around the family fund, around money that we would like to invest into regional support that we get from NHS Blood and Transplant and from Public Health England, about medicines management, and a range of other priorities, like there's money, for example, that hasn't been invested yet in domestic and sexual violence and fractures, in nurse training. It is a combination, effectively, of a wide range, hence the title, of uncommitted areas of expenditure that are planned to happen, which we would love to happen, but are dependent on funding being made available. And they are very important, particularly, I'm sure members appreciate, in terms of particularly those grants to voluntary bodies and the support that is given to us by UK organisations. The difficulties that will be created if we cannot actually fund those the bids and don't receive the money. So apologies for the title, but I guess it's an all-encompassing title of where we're at. Again, back to the issue: why were they not bid for before? They would have been assumed within the overall financing of the entire department. The 160 million was looking at it strategically across and saying these are the pressures, this is what we have. This is basically saying we don't have the money available to make these payments between now and the end of the year, and we need to bid for that money in order for it to be financed. If it's not financed, then it can't happen. So that's the difference between the two strategies. And similarly for pharmacy, in that again, it's money that could be made available through the end of the financial between now and the end of the financial year. If the funding isn't available, then again, decisions would have to be taken about that not happening as well. And that's where you go back to previous Minister's letter of the 28th of August, which set out the whole kind of list of the detail around that. The bids are effectively picking up from that and saying, right, these are the things that we require funding for to enable them to happen between now and the end of the financial year.
Thank you. I'm glad you explained that, because other departmental priorities, they're actually really important priorities that sometimes keep our health service afloat, a lot of those priorities. And I'm glad you brought that up. On the part to do with the 18 million for pharmacy, have you foreseen any pressure that has emerged over the past few months that would call for that amount?
That's looking, certainly we would love to put more investment into pharmacy, and we've also been looking at community pharmacy remuneration, as we discussed at the committee last week. So it's recognising that more money could go into there if it was available. There are, yes, we continue keeping an eye on pharmacy and what is going on. It's a big spend area, but it's recognising that £18 million is what we believe we could invest between now and the end of the financial year. If the money doesn't come, then we will not be able to invest it.
Well, it's actually good to have that, because I know we're probably all starting to get lobbied at the moment for Pharmacy Week in October. And I know we live within our communities, we work within our communities, and pharmacy has been under immense pressure and is an integral part of the whole system. Another thing I want to ask you about, and I don't know whether to be extremely happy about this or extremely worried, is in this monitoring round there's no bid for family health services, children's services or support at home, and I believe they were all categorised as A in the June bid. So is it because things are going really well?
It means that the money is being spent, absolutely. So yes, in one way good, but equally that creates the pressure on the other side. So every single one of those areas has experienced an increase in expenditure. That money is being incurred day and daily, and therefore they're not on the list to be bid for now, because we can't do anything to stop them. They're effectively already there.
Well, that's positive. It is, at least. Thank you, Chair.
Okay, thank you, Paul. Roy?
I hear in the media that the head of the civil service has likely advised the Treasury that I think it's about 4 departments are reaching their expenditure limits. Is the Department of Health one?
In terms of where we are at the moment, in 14-15, we are, at the moment, we can technically break even, would be the way I would describe it. But it does create with it, as you'll appreciate, a significant range of consequences. So we would be very concerned in terms of our response to the head of the service, that whilst technically you can break even, the consequences for patients and clients, you're talking about having to close facilities and restrict hours. So yes, we can technically do it, but the consequences of it are very, very significant.
Can you advise us in terms of your expenditure profile? I would suggest the summer months would generally be, you wouldn't spend as much as the winter months with all those additional pressures. Where are you in terms of your expenditure profile? How much have you overspent to date for the first 6 months?
Well, in terms of the actual profile of trusts, they would forecast that they would be overspent to the tune of over 130 million if things continue as they are. We therefore need to look, as we are, about what that will actually translate into, and how you actually manage and control expenditure back down. And that's the challenge, because what this is about is saying we could stop these amounts, these particular proposals are stoppable, and that's how you bring break-even back, because you can't stop existing expenditure in terms of what you would actually do.
So are you saying about 130 million worth of expenditure would have to be also stopped, so that's not incurred in the second, apart from these other savings?
Well, that's a forecast to the end of the year, and I guess that's what's really behind the figure work. So you can understand the importance of both urgent decisions around this and that the ability to break even will reduces on a day-by-day basis as we
Quite
look
serious.
forward. Very serious.
I see in the bid there's a bid for 4 million in October for the departmental and the arm's length bodies running costs, which did not appear in June. And the paper explains that in September, Minister Putz authorised a reduction of 2.5% to the running costs of the department and some arm's length bodies. Can you clarify how come such a short time later the new minister is now bidding to essentially reverse that?
What Minister Putz did was say, as I think is the approach that has been taken across quite a few departments at the moment, is please, we couldn't afford to wait any longer in terms of signalling that a cut might be necessary. So what they have been advised to do is to plan on the basis of that 2.5% cut. And of course, if money could be made available, that cut would be restored and the budgets would be increased. But it is highly dependent on the money coming back through the October monitoring process to enable it to happen. It was prudent in terms of understanding, well, if the more notice that you give to an organisation, that the more likely it is that they are able to achieve that reduction. So they were advised to plan on the basis of that 2.5% reduction. And what Minister Wells is saying is if funding could be made available, then those cuts could be restored again. So it isn't a change of approach, and it is consistent with the letters which were issued in line with the decisions of Minister Putz.
But is this not a lack of forward planning to give people significant warning and time to implement changes that were being...
That's why we took the decision to actually put them on notice to say, please plan at that 2.5%, which was done after we knew the results of the June monitoring had not materially changed where we were.
Okay, going on to another area then. Bids are supposed to be made by the Department of Health, and the Department of Health has total flexibility with its own budget, but if it's wanting to make new bids, it's meant to be in major and unforeseen circumstances. And I see one of the issues that's been listed is ICT licence renewals. How could that not have been foreseen, whether or not computer software licences were needed or not?
ICT licences is actually a capital priority, and we're the same as every other department in terms of capital, so we are allowed to bid. The major and unforeseen definition only applies to our revenue spend, not to our capital spend.
How have you not been able to plan that you need to get a software licence? Did you not know you needed to get a software licence?
The major and unforeseen element is nothing. It doesn't apply to the capital budget. We are allowed to bid for any capital.
No, but why was it not already in your expenditure plans? Because did you not know you needed?
It wasn't profiled within the capital budget.
I don't understand how it was missed. Can you explain why it was missed?
We've been looking at the various options around it. I don't know whether, Bill, maybe you might want to comment on this in a bit more detail, but we'd looked to see what was viable. We looked about timings and about whether this was going to hit in 14-15 or not. So that's the kind of issue there. Bill, you want to?
No, there are some possible choices in terms of which licence that you might take and how long they might last for, and in terms of the relative value for money of them. There would be an option where we could spend £2 million this year and simply renew the licence for existing type software. This option is where we could renew the licence, upgrade the software and enhance the mobile capacity of the system for mobile working. So it is a bid that contributes towards the ability of our system to work mobile.
Just in terms of all the monitoring rounds during this particular mandate, how many bids have there been during this mandate? And how many of those monitoring rounds have the department bid, which are meant to be in this category of major and unforeseen circumstances?
We've bid, I would suggest, in most monitoring rounds. I haven't necessarily been successful in all of them. And, you know, we have certainly had in-year monitoring money provided to us, which has been most helpful in terms of where we have got to. I think we have probably bid in each of the monitoring rounds, and we are, a large portion of those bids have been around the familiar stuff that we debated with the committee around, the likes of elective care, for example, around TYC, and a range of winter pressures and emergency pressures and whatever similar bids that are here. The scale of them, though, has considerably increased, as I know you'll appreciate, going into 14-15.
And how many of those monitoring have those bids been for current expenditure?
In terms of the recurrent expenditure, elective care and TYC can be looked at non-recurrently, because you can effectively start and stop that, or in large portions of it you can. The remainder, winter pressures, I guess, as well, can be non-recurrent support through winter. There is no doubt that our recurrent level of spend, though, has been increasing above the level of the budget that we have available to us, and that's got gradually worse as we've gone through the budget period.
Where I'm really going towards, are we sort of reached the stage within the planning process that over this last number of years you've assumed almost that significant current expenditure would be got within in-year monitoring?
Certainly in terms of the level of the pressures, they are growing year on year, and therefore the need for in-year monitoring money is significant. And as we look at 15-16, that with a new budget process effectively for that year, that effectively is exactly where we are, which is again increased pressures moving forward, and therefore the need to rely on further funds coming towards us.
And would you agree that in-year monitoring is an unstable form of funding, it's inefficient, and can actually end up making bad decisions in terms of your financial planning because you've limited choices? It
certainly is less certain than having it in the budget right from the very start of the year. I would absolutely agree with that. And really, as we look at the financial years, as the committee will be aware, from last autumn time, then things became exceptionally challenging from the department's perspective, such that we ended the year with the overspend and what have you, and we roll them forward into 14-15. So yes, if we can get money into a budget into 15-16, as we look at that year, that would be highly helpful. I'm just not sure about the ability to do that given the scale of pressures that are presenting across the piece for 15-16.
But would you not agree that in order to get the best value for money within the health service and the best service possible for patients, that it'd be much better planned in advance and living within whatever that new increased budget would be than this stop-go approach which we're seeing here today?
Certainly to have clarity for 15-16 and as many of our pressures covered as possible would make life a lot more straightforward, absolutely.
Thank you.
Thank you. Right. Fergal, next.
Oh, thank you, Chair. I could touch first of all on the issue that I thought might be a small issue at the start, but may, depending on your answers, be longer than that. So, can I just look at the overall bid in its entirety from June to now? The June 1, as I understand it, was uncommitted funds solely. Is that right?
No, the October one is uncommitted funds. The June one's looking at pressures across the year. So October is uncommitted, June was pressures across the year.
So why are we getting wages now in the October one?
Because they're uncommitted at this point, those decisions have yet to be taken. So if funding becomes available, potentially that pay award can be made. If it's not made available, then it would be stopped.
Okay, all right, I just need to get that clear in my own head. Just for aware of that. So can I touch on one particular budget, the pharmacy budget? And can you tell me how much did you get from the PPRS scheme in the first quarter of this year?
And the only money we've got from the PPRS scheme relates to January, the first quarter, January to March of last financial year, I guess. We got 2.9 million, I think, was the number there.
So would you expect that you would be getting that across the year reflective of each quarter?
We have yet to be clear exactly how much we were getting, but yes, we would expect more funding obviously to flow through to us.
So it could amount to something like 12 million?
We don't know, but yes, we expect it to be
so. In other words, but what process are you getting that money back through?
It goes through, it comes initially through to DOH and then comes back through to ourselves. The actual apportionment is a complex area, as I'm sure you'll appreciate. The apportionment of it between the various countries is still being worked through and hasn't yet been finalised, but ultimately that will come through. Where it then sits is within the pharmacy budget, because effectively that will offset any growth within, or hopefully will offset the growth within the pharmacy budget that would otherwise have been there.
Shouldn't we simply then subtract that potential 12 million from the 18 million bid you've been?
No, because we have assumed that whatever, because of the way the agreement is set up, any growth within our spend will effectively be offset with that monies. So effectively, it's dampening down the growth within the pharmacy budget.
And are you saying that PPRS money is going only back into pharmacy?
It's within the pharmacy budget, that's where it will go, and it is because it's against the pharmacy spend, and that's what it's set up to do.
Yeah, I think the public mind around pharmacy spend might be, maybe I'm talking about my own confusion rather than the general public mind, but pharmacy, in my understanding, would be the drug end, if you like. So is it going simply back into the drugs?
The drugs would otherwise be, the cost of the drugs would otherwise be higher than with that scheme in place. Absolutely. So it brings the cost of those drugs back down.
So just to be clear, you're saying that your bid without that PPRS scheme would be 12 plus 18, is that what you're saying?
Yeah, we would, without the PPRS scheme, we would need more money, absolutely.
Okay. Right. I would have assumed that you would subtract this new money, and it's in this year, and you don't know exactly what it would have been potentially. There's new money coming back to you, if you like.
Yeah, but you're right in terms of if we didn't have it, we would be £12 million worse off than where we are at the moment.
Can I also just look at another area? Meanwhile, where all this pressure's going on, you're merrily recruiting and at the board, and as I understand it, you've got an increase of somewhere between 20 and 30% in board staff over the last 2 years. Can you explain that?
Do you want me to pick up on that? You're right in terms of the increase in this across a whole range of areas. Some of it relates to staff who are on fixed-term contracts who will not be permanent, and those will cease. But there are a range of areas where there has been increased work over the recent years, and staff have been taken on board to address those issues. Say they're in different areas. I mean, this is an area we know there has been a focus on, and I know that this is something that the Chief Executive of the Health and Social Care Board has said that she will be looking at, so that is something...
How did you get to a state against the backdrop of a moratorium on civil service recruitment and a flatlining on pay, increasing your staff in the last 2 years by whatever means 20 to 30%?
I'm sorry if I'm not clear on it, but in terms of the board, they're not civil servants, so there hasn't been a moratorium on recruitment within the Health and Social Care Board. So there have been increase in staff. There's some of those areas, I say, that in terms of the work that's been taken forward, it's on a fixed term basis. Those numbers have been brought in, they will leave again. But it is right, there has been an increase
just to clarify, there's no moratorium, or there has been no moratorium on civil service recruitment either. Now, what needs to change potentially moving forward is a different thing, but for up until now, there's been no moratorium on recruitment.
But sorry, I still haven't heard an explanation of how you can justify an increase of 20 to 30% in your staff at a time when we're sitting discussing here huge pressure on budgets. You're looking after your board, and there's another 600 staff in the department.
No, it's absolutely important to be able to explain where there has been that increase.
Can we get an explanation?
But I can explain some of it, I hope, to you. In terms of where the increases have been, they've been right across the different areas within the board. I'm just looking at in terms of admin and clerical. There has been an increase there of...
You're pointing to the figures. What's the rationale?
Well, as I say, some of it, for example, is transforming your care. There would have been staff have been brought on to the Health and Social Care Board to address some of the issues in relation to transforming your care. That is something that didn't exist 5 years ago. And say in terms of some of the staff that are in those areas are on fixed term contracts, and they will be there
So
for
can
a
you say
year.
that represents the 30% then? Is it Transform Your Care
Oh, no,
partially the answer?
No, but that's an element of it. That's an element of it. But there's also been increases in terms of commissioning staff and integrated care staff, and also there has been a significant increase in the area of social care and children's services, and that's because of some of the increasing demands and the issues that need to be addressed there. Now, I don't have further detail on this, but we are aware of the increases. We're aware of where the areas are. We know that it's something the Health and Social Care Board is
Could
looking
you
at.
understand how there might be a reasonable level of public concern when these figures are revealed to them, that you guys are recruiting merrily, while services to the public in general are not being delivered satisfactorily? And in fact, you're recruiting and the service is worsening.
Well, I think it's absolutely important where there are increases that they are able to be explained so that the public do understand.
But I'm not
This
hearing
is-
an explanation here.
But this isn't a case of increasing staff for the sake of doing it. There are changes that are happening, some of the transformations, some of the increased statutory responsibilities. We need staff to deliver those. The Health and Social Care Board would go through a rigorous process in terms of satisfying itself in terms of the necessity for the staff, and I say that is something that I know the Chief Executive says she will be looking at. But absolutely, we're aware of the areas where there's been increases. When there is an issue like this that is likely to cause public concern, it's not simply on that basis. We would be looking at the areas where there's increased expenditure and ensuring that that's justified. But absolutely,
Well, you've had raised the issue. Is it justified?
we have nothing to indicate that it's not justified, but we absolutely will be looking at it with the Health and Social
But
Care
if-
Board.
if-
I maybe add as well, sorry, just that the 2.5% cut applies to the regional board, and obviously then to our own, you brought in our departmental budget, and that's on top of a 4% sort of increase we had to effectively manage. So that's cut that we're already been managing. So there's been significant reductions on both on that as well in terms of our own departmental.
But your overall expenditure's gone up from some 21 million to over 25 million.
That's within the regional board, and that's what the council.
Yes, so you've increased your expenditure by £4 to £5 million.
But within the board, that
Annually.
expenditure has increased. But absolutely, it's right to be concerned about increasing numbers, but we have to recognise what it's there to do. I am picking out Transforming Your Care, but to say the area where there's been the biggest increase within the board is in relation to the children's services, and that's because of the increased requirements on the board there. It's essential to have the staff to deliver these. It's essential to, we can't make the changes required without having the staff in place to do that. And so there has been a change in the requirements within the board, and that is reflected in the staff. We would expect to see changes in those numbers moving forward as, for example, the transformation is implemented. And I've said, some of them, there's a number of staff there who are fixed term. We would expect to see the numbers go down when their contracts end.
Chair, I just think it's an issue of concern. There's 600 staff on the board, an increase of 20 to 30% in the last 2 years. The department employs 600 as well. You're also talking about bringing in commissioners and ICPs and local commissioning groups. Can you tell me, is there duplication here?
We're working to ensure that there is not duplication, that services are delivered in the best way. You mentioned I think you mentioned the integrated care partnerships. The integrated care partnerships is something that is regarded as an absolute key and important element of transforming your care. That's about bringing together a collaborative network of GPs, pharmacists, voluntary and community groups that cannot get together to properly inform the development of services, the development of clear patient pathways. We see in front of us today the two bids that are going through for Transforming Your Care, which if delivered can actually make a significant difference in terms of maybe not cash release savings, but the avoidance of future costs to the health service in terms of stroke fixing. That's just one example. The reality is you need people to do that. It's simply, we can't do it without putting in place the arrangements to allow those people to get together to actually develop that work. And certainly in terms of the transforming your care, looking at that assessment that's an investment to save, and those costs won't continue forever.
Yeah, and that's your perspective. And what I'm seeing from my perspective, and I meet a lot of different organisations, is you've got to transform your care plan. You've got a deterioration in the provision of services over the last 2 years. You've got a bloating of the board in terms of administration by 20 to 30%, a £4 to £5 million increase in expenditure, and somebody somewhere, Chair, I think should come before this committee and start answering questions about that. Thank you.
Okay. Thank you, Fergal. Joanne, next.
Thank you, Chair. Could I take you back to questions that Kieran started asking earlier, and it was about the pressures around the winter months. And just looking through your summary of options on page 18, there's one short sentence about winter pressures. And I know, Catherine, you spoke earlier about the flu vaccination, the GPs, and how that already has begun. So can you give me your assessment of the services most likely to be under pressure, and what steps you take to support staff to manage that demand? Because as we all know, staff are under so much pressure, many are at breaking point. So can you maybe outline that for me?
I absolutely. There are a raft of issues here aimed at addressing the pressures that the emergency departments will face in terms of the winter months. There is also emergency department capacity planning, because we recognise that in order for the system to work effectively, there are capacity issues there, and that capacity planning is important. Also, 24/7 hour working. The health service is a 24/7 hour system, and we need to look at providing the funding to enable that to happen, and also for the GP out of our system, because, and I think I said when we were given evidence to the committee last week, that if you look at all of these bids, there are none of them that actually stand alone. They are all related, and when you look at that unscheduled care and patient pathways, it's all contributing to the effective running of not just the emergency departments, but effective discharges and effective working with the GP out of hours. And the GP out of hours, they come under significant pressure at times of public holidays, for example, and they are, they take a significant pressure off the emergency departments. If we don't look at all of these elements, then it's like squeezing the bubble. Then, for example, not addressing the issues in relation to GP out of hours will put an increased pressure on the emergency department. But that even goes to the elective care bid that we talked about earlier. We talked about the potential for extended waiting lists now. And if we have people who are waiting for hospital appointments and their waiting times longer, then there's potential for that to increase attendance at emergency departments. So there are a whole raft of issues. I could talk you through some of the actions that would be intended.
To support the staff, because staff do feel they're not being supported, and they do feel, even when they contact us as elected representatives, they're saying, please don't let my name be used. They're afraid of reprisals as well. And it's for morale, for frontline staff, that to be morale to be so low, and the hours that they're working, it is a breaking point. So if you could outline.
Well, absolutely, and I would repeat what the Minister has always said in terms of the work that is carried out right across the health service 7 days a week, and obviously without the staff we couldn't do it, but the commitment of the staff is absolutely phenomenal. All of this is about supporting the staff. It's recognising the pressure they're under. It's putting in, it's trying to put in place the additional help to free up and give better provision, better resources right across the emergency departments. Also, as well as the funding that we're bidding for, I've mentioned earlier that there's the Emergency Department Task Group that's been set up, chaired by the CMO and CNO. Again, that is looking at how there is more effective working within the emergency departments and all aspects of unscheduled care. And right at the heart of all of that has to be the consideration in terms of the impact that this has on staff.
So if you have this in place, I should see a reduction of staff contacting me through the office about the pressure. That should be what you say is in place then.
That's right. If we were able to put in place what's required, then absolutely that should take the pressure off staff. And equally, if we're not able to put it in, that pressure remains.
Okay. Supplementary, Chair, for me.
Go ahead.
You say your aim, and I quote, is to avoid admissions, improve patient flow, improve discharge arrangements and enhance community service to support discharge. These are major challenges which require investment to deliver the savings, as Roy outlined earlier. Were NISRA statistics used to predict future population growth when the original 2011 budget was set? Because obviously demand is outstripping the budget.
Sorry, I have to...
Yes, we factored in demography and we look at population growth through the piece. But equally, for example, the numbers of children that, just to use one example, looked after children is considerably higher than any population growth would ever have indicated. Now, that may be to do with society, it may be to do with different children's issues, the Savile Inquiry and things like that. But, there are pressures that present that are on top of a demography pressure. There, and new treatments that present that again increase expectations and that people would wish to see funded. So, demography is an element, absolutely, of what we bring into the budget as we look at it, but it's by no means the end of it, and the demand can most definitely outstrip that population growth aspect.
And finally, and Kieran did touch on it earlier when he started his questions, can you provide us with an update in the St Ulster Hospital? Because I think it's important that the committee know what internal escalation measures, I think you call it, were instigated at the hospital, including the impact on the patients, because we've had so many of these incidents, and the worrying impact on the patients as well as the staff, the impact on them, and what impact will the current budgetary position have on the future likelihood of dangerous incidents such as what happened to the Ulster and what has happened across the board in other hospitals?
In terms of the emergency department performance, I can tell you that certainly the figures this morning indicated that there weren't any 12-hour breaches as we currently stand. This is something that the Health and Social Care Board is engaged with the various trusts on, and when there are issues that are exceptional, as has been the case with the South Eastern, that's where there will be an escalation plan put in place, and the board will work with the trust to look at the reasons why that occurred, whether the escalation plan is effective, and what measures would need to be taken. All of that will be considered in the context of everything that is happening around the unscheduled care programme in general, and including that is something that I would expect that the task group will also, take into account in its considerations. But at each stage when this happens, the board is very much engaged with the trust in terms of the reasons for it, ensure escalation is effective, and assure that there's any immediate steps that need to be taken in that respect are done. I've just looked to see if I had more detail. As I say, I know that certainly at this morning none of the trusts across the system were experiencing any 12-hour breaches, but the performance has not been good in August, and we certainly know there's been 142 12-hour breaches in the Belfast Trust. We know that all of the trusts are working at the minute in terms of unscheduled care implementation plans. This is something that they're engaged with the department and the task group in developing these to ensure that measures are taken
I think, Catherine and Joanne, I think it's important, obviously, in terms of our piece of work around monitoring EDs, but I don't want to get into the specifics around individual trusts or hospitals today. I think if you want to share information with Joanne that's useful, that's fine, but I want to remain on the key.
Because that can be brought up
context.
under any other business rather than on this.
We can come back to it. Okay, you okay with that?
Kieran brought it up earlier, so just following on for, thank you.
Okay, Joanne, thank you. And finally, I have Gordon.
Okay, thanks, Chair, and thanks very much for your input today. Just in relation to clinical negligence, I understand there was £10 million in the June monitoring round for that, and I see that it doesn't feature in the October bid. Are we improving in relation to that, and what measures are we taking to reduce the risk of clinical negligence, and what are we doing to address issues that have been found?
In terms of why it's not on the October bid is because effectively that expenditure will be incurred. There's nothing you can necessarily do within a year to prevent it or to stop it. The settlements will be made by the courts, and they are whatever they are, and we need to cover those. Certainly we expect the expenditure in 14-15 to be less than in 13-14, and the range of issues that we're looking at to try and improve this for the future around the Quality 2020 agenda, and about looking to ensure that serious adverse incidents and adverse incidents are clearly understood, that lessons are learnt, and that people are treated appropriately through those various processes. So the quality reports that come out from organisations about how trusts are getting on, all of that committee agenda is all aimed at ensuring that clinical negligence will ultimately reduce, looking at if there's means of alternative dispute resolution, looking at mediation, all of those, but they wouldn't impact in the 6 months between now and March. If you like, the period of time is just simply too short. So it's not there as a bid because effectively the bid has been built up based on where we could take decisions to stop or control expenditure, and hence why it's not on the list for October.
So those issues are taken seriously and addressed
Absolutely.
to stop recurrence of something that has happened. Just a couple of other things in relation to EDs, and it has been touched on. There's a bid there for £1 million. We've had RQAA carrying out a review of unscheduled care. What's the impact if you don't get that £1 million? How do you see that impacting on this continuous problem that we seem to have within the health service about EDs and how they respond to increased workload?
The impact is that we would not be able to take forward and implement and full the RQIA recommendations. Throughout this unscheduled care bid reflects the funding required for the implementation in substance of the RQIA recommendations. So if we don't get it, we wouldn't be able to do that, and clearly that will impact on the ability of the emergency departments to deal with patients in a safe and effective way within the targets that have been specified.
So it's a priority?
Oh, it's absolutely a priority.
Are you reflecting that up to the Minister, that this is a priority?
We are, that's absolutely in the advice, and that's categorised as top priority within the categorisation of the bids.
What about elective care? We touched on it last week as well. Elective care to me is a very serious issue, £21 million in there. How do you see that? Is it within your priorities?
It's categorised as Category B for the reasons that we'd explained, or Julie had explained earlier. It's not that that's not important. All of this is so critically important. But it's absolutely, I would say it's absolutely critical. The issue is we already have 84,000 of a gap in terms of outpatient assessments, and 25,000 or 24,000 in terms of inpatient day case treatments. This will actually fund, if we were successful with this bid, it would fund almost 20,000 assessments and over 7,000 treatments. The board would be able to address then the rest of that gap. So effectively, this would be the funding that would be required to enable patients to be addressed within the specified targets for waiting times. The waiting times have been increasing over recent months. They are increasing further in current months. Without this funding, those will increase further. And as I say, there's no element of this that you can look at in isolation. If there's an increase in waiting times, that has the potential to increase in emergency department attendances.
It's critical we get it. It's critical we get this funding and the 21 million. Just finally, 160 million is what's needed. With 100 million, could you keep the lights on with 100 million?
We're making a bid into the centre at 130 million, and absolutely 100 million would help to avoid the worst of the consequences. The list of things that would have to happen are effectively these bids at 130 million, and we, the more money that we can get against those, most definitely the better in terms of avoiding the consequences. They're all very high priority areas right across the system, and we need urgent clarity about how much extra will come to the department, and then allow that to be invested in the services between now and the end of the year. Absolutely vital.
Okay, thanks very much. Thanks, Chair.
Thank you, Gordon. I mean, just on that point, Julie, there were some local media today indicating from a comment from the Minister that 60 million could, I suppose, take us through. Where did that figure come from?
I think the 60 million number is which is on top of, I understand, of the 20, that on the presumption that 20 would be received, is an unofficial number, but one that is in the public domain around discussions at the executive level. But it wouldn't be appropriate for me to comment any further about executive discussions.
So that advice in terms of the 60 million wouldn't have been advice from yourselves?
Well, in terms of, obviously from our perspective, the more money that we can get, the better. That absolutely would be the case. And ultimately it's a matter for the Minister about how far down the list and how much money he believes is necessary in order to make the decisions as we move forward and make the investments that we need.
Okay, well look, can I thank you for your attendance. I would stress that I think that it goes without saying that all of us recognise the strains and the pressures within the system. However, I am very clear that what I've heard today hasn't satisfied me in terms of the information that's been given. We have been told in the June monitoring round that there was 160 million needed that was critical. We were told then that it was 140, which then became unfunded pressures, which, last week we were told was an overview of the current financial situation. Now, this week, we have a bid for 130 million. We have found 10. And we can't be clear on where the 20 that is conditionally allocated will be spent. And, as far as I'm concerned, I see a policy shift in terms of where some of these priorities now lie. This is a very different document that we're looking at this week than we looked at last week. And I do think that we do need to highlight things like the policy shift or policy focus shift on issues like TYC. When we see that big shift, Julie, from 21 million bid in June to 2.6 million, on the key component, the key plank of what we need to deliver health. It's a huge shift, and the principles of shift and left, the public health bid of 10 million, only 3.5. I mean, somebody somewhere has had a shift in terms of priorities or focus. And I have to say, I'm not satisfied as chair with what I've heard today in terms of giving me confidence. And this isn't about rejecting bids. This is about us as a committee doing our job and being able to stand over a robust piece of work going forward with confidence. And I haven't heard it today.
I can assure you that there has been no shift in strategic focus. The list of the bids reflects purely and simply the amounts of money that are not invested yet between now and the end of the financial year and for which we require additional funding. That's how the bids have been put together. The moves, therefore, between June and now, for example, in the public health one that you point out, the money, the difference, £5 million of it, has already been invested in vaccinations, so it's not a policy shift. That money has gone into public health as was originally intended. That is part of what's creating the £140 million gap. Yes, we've then managed 10 million of that to create the bid of 130. The bid is shaped around where there are effectively choices as we look forward. Either money becomes available and they're financed, or money doesn't become available and they're not. That's where the difference in terms of the amounts are, and in terms of the priorities are the same as they were before. So I know that is complex, and the budget most definitely is complex, but the reality of these October monitoring bids, they are all around the areas where we can actually take choices and stop expenditure, and that it's a factual reality, as opposed to where you would want to stop expenditure or anything of that nature. And it's simply therefore to the executive to say, well, if money could be made available, these are the areas that would be able to be continued, and that's the difference. So it's not about a policy shift from one to the other. It's simply referring to the factual reality of where we are at this point in time, with 6 months to go before the end of the year.
Well, okay, because I'm going to close it down, but I would say in response to that, we have been given clear examples today, and we have presented you with clear examples of where there has been a shift in priorities, because there have been bids produced in this round that weren't in June. So it's not appropriate or correct to say that it's the same list going forward. It's certainly not, and we've highlighted a number of them. The pay awards, we've highlighted the issue about the ALB's cost.
Again, because those are areas where a choice can be made because the funds are not committed. They're on the list simply and purely because they are factually where money can be stopped, where a pay award can either be issued or not, where an ALB cut can either happen or not. That's why they're on the list, and it's gone right across the budget, and the entire analysis there behind the bids is around that particular issue, which is about where choices can be made. We're asking the executive to consider, therefore, whether funding should be provided to allow those services to continue, and that's where they are. That's a completely factual analysis of what remains to be spent between now and the end of the year, and if we don't get the funding, those will have to all stop.
Okay, well look, can I thank you for your attendance, all three of you today. Thank you.
Okay.
Okay, members, just in going forward on this particular item, I'm just seeking a view from other members here as to next steps. I would suggest that we would write to the department to express some of the issues that have been raised today in relation to the information that we've been given, and indeed certainly my disappointment that we haven't been given the appropriate information that has indicated why there has been a shift in some of these priorities, and indeed some of the issues that we've raised generally today. And I would also go so far as to say that I am disappointed, given the enormity of this situation, that the Minister wasn't available or didn't make himself available to attend today. This is critically important to get this right. And I say that knowing that all of us are collectively trying to work to address the strains in the system. But equally, in terms of our role as a scrutiny committee, we would be failing our responsibilities if we didn't do that robust piece of work around the monitoring round.
And specifically, Chair, that issue around the increase in board staff. Are they paying board staff now to do TYC work? Doesn't have the money to follow through on it. I mean, there are questions, very specific questions around that. There's a huge increase in their budget over the last 2 years, and it just seems to have gone, if you like, unnoticed and not defended at this level. And I think we need somebody at the Chief Executive level to come before the committee and explain what's going on at the board. There's 600 people there, there's 600 people in the department. You've got trusts and all sorts of layers of administration here, and we're not getting a result for it.
Suggest that on that as well, we have an evidence session as part of our review of the budget going forward the 2015-16, that we invite the Minister to that session, which is on the 22nd of October.
Just to follow up, Chair, I mean, what was said there about the pressures, or the forward winter pressures, as I said in my contribution, they're talking about that now. I mean, look what happened during the week in the Royal and in the Ulster and other places. At this moment in time, we're still in the summer period. They can't cope. What's it not going to be like coming winter unless something drastic is done?
Yeah, and I think that's the general view as to the lack of information that we received, or the levels of information that we received around shifts in this approach to this monitoring round. Okay, so I'm taking it that we are going back to the department to express disappointment about what we heard today. There are specifics within that I think that Fergal has raised, one of them, that we need to come back to with a view to asking the Minister to attend the evidence session on the 22nd of October.
Thank you, Chair.
Okay, thank you. Okay, members, item 5 is the secondary uses of patient information legislation. Just want to refer members to page 67. It's a tabled folder, sorry, for the relevant papers. Again, just advising you that departmental officials are here today to outline the proposal to introduce primary legislation to extend the use of service user identification information to include secondary use in controlled circumstances. Officials will be accompanied by Professor Roy McClellan. You're very welcome, Roy, Chairman of the Privacy Advisory Committee. So you're very welcome to the meeting. We have Sharon Gallagher, Director of Corporate Services, and Chris Matthews, who's Information Management Branch at the department, and Roy. So I'm going to hand over to yourselves, folks, and we will open it up to questions then, please.
Thank you. Good afternoon, Madam Chair and members. Thank you for the opportunity to set out the Department's proposal to bring forward legislation to enable personal information of health and social care patients to be used for purposes other than their direct care in limited and controlled circumstances. You will be aware that the Department's proposals are currently out for consultation. Members were provided a copy of the consultation when it launched on the 7th of July. A further copy has been enclosed in your briefing packs for today. Currently, the HSC may share patients' information for non-direct care purposes if consent has been given. Where consent is not possible, new arrangements have been put in place to allow for the sharing of information where the patient's identity has been anonymised or pseudonymised. These arrangements will enable an improvement in the planning and delivery of services and support ethically approved health and social care related research. Even with these developments, there are instances where access to identifiable patient information is needed to secure the required outcome. Under current arrangements, patient identifiable information may already be used for purposes other than direct care, as long as the requirements set out under the Human Rights Act, the Data Protection Act and the Common Law Duty of Confidentiality are met. The requirements of the Human Rights and Data Protection Acts are clearly defined. However, aspects of the Common Law Duty of Confidentiality are less clear. Under the Common Law Duty of Confidentiality, where consent has not been given, personal information may only be shared if there is a statutory basis for doing so, or if disclosure is deemed to be in the public interest. At present, because we do not have statutory authority, the use of patient identifiable information for any purpose other than direct care is predicated on the organisation's ability to satisfy the public interest test. Deciding what is or what is not in the public interest is open to interpretation, and this creates a significant risk for patients, the health and social care organisations that hold the information, as well as those who are using the information. The ambiguity about what constitutes public interest means that decisions may be more subjective and prone to legal challenge. This is where the proposed legislation will come into play. To mitigate against the risks outlined, the proposed legislation would put in place a statutory framework which would clearly define the circumstances under which patient identifiable information could be shared for secondary uses. The proposals would remove any ambiguity and safeguard the patient, the HSC and the information user. Safeguards will be a key element of any changes, with robust controls and protections in place. For example, the proposed legislation would confer upon the Department the authority to establish an oversight body which would critically assess any requests for access to information. Given the importance of the safeguards, the detail and the governance arrangements will be subject to a separate consultation process which will inform regulations. That said, as a general point, the Department would envisage that approval to use patient-identifiable information would only be granted where it can be proved the results could not be achieved without access to the data sought, that it is not possible to secure consent, and that anonymised or pseudonymised information could not provide the same outcome. It is important to emphasise to the Committee that in the majority of cases, information that does not identify the patient will be sufficient to deliver the required outcomes. I would also stress that it would remain the Department's policy that primarily an individual's consent be obtained for the use of their information. In conclusion, there is just over 1 week of the consultation left to run, and so far 13 responses have been received. All have been supportive. In addition to the normal public consultation process, the Department has engaged directly with a number of key stakeholders, including Disability Action, the Northern Ireland Human Rights Commission, the Northern Ireland Law Centre, the Patient and Client Council, British Medical Association and the Information Commissioner's Office. We appreciate the opportunity to address the committee today, and I'm very happy to take any questions.
Thank you, Sharon, for that. Just in terms of the consultation process, because you talked about separate consultation process, is that what you're alluding to around alongside the standard consultation? You also engaged with the Law Centre Human Rights, or is there a separate process?
No, Chair. We're running a second consultation process pending the approval of this part, the bill, to inform the regulations which would set out the safeguards and governance arrangements. We feel that the safeguards and governance around the protection and confidentiality of patient information is so important that we want to run a separate consultation on that.
So there's a week left to this consultation?
To this consultation, which will inform the bill.
And you've, alongside of that, had a separate process of consultation?
Just purely engaging informally with key stakeholders, just to make them aware of what our proposals are and to take their views as we develop the proposals.
And then you're proposing an additional consultation?
An additional consultation to inform the regulations pending approval of these proposals for the bill.
And what timeline or timescale is on that?
We're hoping to, pending the approval of the bill, we hope that that process will finalise in October 2015, and only after that then would we launch the second consultation in terms of the proposals for the safeguards.
Okay, October 2015. Okay, Kieran?
No, just is the information used for within Northern Ireland, or is it shared with other jurisdictions?
Primarily the use of the information will be within Northern Ireland.
Within the, okay, that's fair enough.
Okay, Joanne.
Thanks, Chair. Thank you for your briefing. Can you tell us when the arrangements to enable specific sharing came in England and Wales, and what benefits has it brought there?
Well, in England they passed the legislation, I think it was in 2001, and they've had the legislation in place since that time, and they've been able to make use of it for planning and for a range of other purposes, where, for instance, asthma and some other diseases where they've used the identifiable information to look at how they can deliver and improve their services. So they have a process in England, and they would have come to us up to now and said, you know, could we look at this on a UK-wide basis? And they would approach Roy as the chair of the Privacy Advisory Committee. But unfortunately, because we don't have the legislation, our answer has had to be, we can give you anonymised information or you can get consent, but you could be talking about thousands of people. So we haven't been able to be sort of linked in with other UK-wide initiatives in that area.
How do your proposals for legislation differ then from England?
It would be very similar.
Very similar?
Yes, and there would be the same governance arrangements, robust governance arrangements put around that process.
You say in your briefing that the administration of their winter fuel payments, for example, to cancer patients was complex under the current system. So how would you see this changing under your proposals?
Well, under these proposals, the difficulty was that the department couldn't access the identifiable information of those people, and they could be receiving treatment in a range of different locations. So one of the issues was about identifying where there were duplications of the patient's record in a number of areas. So because we weren't able to get the identifiable information because we couldn't apply to the body, then we ran into difficulties about what were the options we had in terms of identifying who the people were. And obviously we came to a conclusion that in that instance the only way was to go through the GPs, who would obviously have up-to-date information. There would be small numbers, hopefully, within each practice, so they would probably personally know who the people were. And we sent a process through them where the person then gave consent, sent that back in, and the payment was then made to them.
So things could have been processed so much quicker.
It would have saved us quite a bit of time to be able to make the application, obviously meet the criteria, and get the advisory group to approve that, to enable the department to actually move that process forward.
Okay, and finally, Chair, how do your proposals sit with the Data Protection Act or other legislation?
They would be fully compliant with the Data Protection Act. That would be one of the provisos in terms of sharing of the information.
Okay. And are you aware of concerns that were raised in England when it was introduced under the protection?
No, there haven't been any significant concerns about this process. In fact, some of the initial respondees who would be very aware of what the process is in England are actually very supportive of it. So obviously that will come out when we review the consultation responses.
Thank you. Thanks, Chair.
Thank you, Joanne.
Paula? Thank you. Just to follow on from what Joanne was saying about the model over in GB, from what I can gather from reading about that, there were criticisms around their CARDAT over there. You haven't, well, how are we going to address, or how are we going to be different to that? We don't face the same criticisms.
Okay, well, the issue they've had recently is around care.data, which is the information centre they have in England for the processing of information. That's a different process than this. That's where they would take pseudonymised or take identifiable information in from GPs, pseudonymise it and then provide it to other bodies. This is about a specific structure that would sit beside that structure, and it would say if you want identifiable information we will consider it, but primarily as we've sort of, as Sharon has set out, we would be putting them to what we have put in place, an honest broker service, and say get it anonymised information. You shouldn't need identifiable. If you do, you have to answer the 3 questions as to stipulate why consent isn't possible, anonymisation isn't possible, and obviously the benefits that will be achieved from getting the identifiable information.
Okay, another question is just, we currently have the cancer registry, isn't that correct? Okay, what's going to be the main differences then between this and the cancer registry?
Is a really good example of why we're looking to
It's excellent,
in place. Yeah, Cancer Registry operate on the test of public interest. They have robust mechanisms in place to protect the data, but there is still the risk of challenge because there's no statutory basis for them to operate. Cerebral palsy is another example, the Register for Cerebral Palsy. So this would actually enable those organisations to have more protections around what they do.
I mean, I'm very much behind this. As someone who worked in the health service for years and knows that information went astray, and you know, if there had been one database that had lots of information on it, it actually would end up saving lives ultimately. So I mean, I very much would be behind that. On the cancer register, there's the opting out. Will that be the same on?
In terms of the opting out process, we haven't gone into the detail of that.
Okay.
That will be for the next phase. So we'll consider it as part of the regulation.
Right, okay. So we'll watch and wait.
I guess the questions that have been raised are very much around the governance, the safeguards, and that's why we wanted to break this into 2 parts and not lump everything together, because we're hugely aware that people are very interested in how this will operate and creating the protections and the safeguards in the right way for Northern Ireland. So at this stage we're dealing with the principle of sharing information. The second stage, which will be set out in regulations and will be subject to committee scrutiny and public consultation, will deal with all of those aspects of opt-outs, of how we share the data of the oversight board and how it operates, because it's very important to us that we get it right.
Oh, thank you.
Thank you, Paula. Roy?
You've indicated there are potential benefits and illustrated this with the cancer registry, register. And yet you said this has been introduced in England in 2001. Why has it taken us so long to move on this issue?
I might want to comment on that.
Well, perhaps because I've got longevity behind me. Privacy Advisory Committee. Privacy Advisory Committee was established in 2006, and we were asked to implement a number of recommendations by the then Minister, one of which was to do a feasibility of and the desirability of legislation. And we reported to the department in 2008 that there was a strong case for introducing legislation along the lines that we have now. We have been keen and are delighted to be at this point in the development. I expect we would have preferred to have seen this happening much earlier, but I think, as the department can explain, they have actually been setting a number of other bits of the jigsaw puzzle in place. Reference has been made to the fact that anonymised information is a much better option if you can maximise that, and processes to better provide anonymised services to allow the health service information flows to happen have been moving on. Better governance arrangements within the health service generally. But Chris can fill in the dots around this, and it's not for me to defend why the department's taken 6 years or more to get to this point, but to support the position that they've got to.
Well, I suppose from my perspective, when I came to the department, we looked at what the issues were around governance within the health and social care sector, and there had been a number of audit reports and recommendations. We then set about, we put together a 3-year strategy. The first year looked at improving how the health and social care sector manage their information, looked about personal information asset registers, senior information risk owners, to put all of those protections and robust governance in place, and also, but not to limit the information, to help them how they could actually share it. Subsequent to that, we put in some additional controls within the health and social care sector to assure the department that they have robust governance in place. Then we introduced the anonymisation and pseudonymisation process just last year. It's called an honest broker service, and it's looking to develop the use of anonymised and pseudonymised information. So only when you have good governance, another process in place, could you then bring in the legislation, to be honest, because the vast majority of cases, as Roy said, should be using anonymised information. So we needed to have a process within the organisation that could do that. So that is now in place and is starting to develop and build its capacity. Now was the time to then start to move forward with the legislation process, which is really the final piece of the jigsaw, as I saw it.
And how do you reassure the public that where you use patient identifiable information, that will be secured and only available to those professionals that actually need it?
Yeah, that's the next part of the process that I referred to earlier. We'd be very clear about the purposes for which the information will be used. They'll be clearly defined and controlled and limited. The oversight group will assess all applications to make sure they're in line with the agreed set of criterion. So that part still needs to be fully defined and thought through and consulted on. But certainly there will be very robust a regime around that process.
I suppose in addition, they'll need to adhere to the Data Protection, the Human Rights Act, and if it's for research, they'll need to have ethical approval for the information to be shared. But ultimately, it's looking to use the pseudonymised and anonymised as far as is reasonably possible.
Okay, thank you.
Okay, right, thank you for that. Could just maybe clarify then, finally, the issue about timelines for the legislation. I know you talked about the consultation, but have you projected timeline on that?
October 2015
October
for this
2015.
piece of legislation, and pending approval for this piece of legislation, we'll begin to consult on the governance arrangements and the safeguards.
Yeah, but that's a timeline around the process in terms of it actually to be introduced.
But the Royal sent for the bill this October. We're looking at October 2015. Then the regulations would follow on.
When it's introduced to the Assembly, thinking, have you a timeline for that?
I think it's starting February, March of 2015.
When this part will be introduced to the Assembly?
Yeah.
We're looking for royal assent in October 2015.
Yeah.
And we haven't fully defined the timeline for the regulations because we want to make sure that we pass the bill first of all.
But the introduction to the Assembly, I think you're indicating what, February, March?
One second, please. Yeah, March, April, we have it as 2015 is our planning assumption, and that's the
February, March
information
2015. Just because, I mean, obviously that's our committee stage starting, so it'll be very clear, and it'd be useful to just share those timelines, exact timelines with us. Okay, well, thank you for that information today and presentation. I think at this point, I'm just going to ask our members' consent to note as it proceeds. Okay. Okay, thank you, folks. Item 6, members, is the Health Miscellaneous Provisions Bill. Page 124 of the tabled folder for the relevant papers. Just advising members that the departmental officials are here today, I'm hoping, yes, to discuss the age of sale provisions for nicotine-containing products in the Health Miscellaneous Provisions Bill, which are currently out for consultation. So we're just waiting on our...
Chair, did you get a chair committee get a letter from
Yes,
the
I was
Chair
gonna-
Starting Stroke? Are you going to?
Yes.
Good. Good.
Okay, you're very welcome. Thank you for attending. We have Dr. Anne Kilgallen, Deputy Chief Medical Officer, Gerard Collins, Health Improvement Policy Branch, and Jenny McIlerney, Health Improvement Policy Branch. You're very welcome. So I'm just going to hand over to yourselves, and then I'll open it up to questions from members.
Thank you, Chair. Just a few short words by way of setting context for you. Thank you for this opportunity to discuss the proposed age of sale provisions for nicotine-containing products in the draft Health Miscellaneous Provisions Bill. I would like to give the committee a brief overview to Part 1 of the bill, which deals with provisions relating to nicotine-containing products, otherwise known as NCPs, and also some background on the decision taken to include these provisions in the draft bill. You will no doubt be aware that in the last 3 or 4 years there has been an exponential growth in the use of the novel NCPs, which are usually in the form of an e-cigarette. E-cigarettes are perceived to be less dangerous than regular cigarettes as they do not involve the burning of tobacco, which results in the production of tar and other carcinogens. The liquid in e-cigarettes generally contains nicotine, along with propylene glycol and glycerine. This liquid is heated and a vapour is released, which is inhaled by the user. This has given rise to the term vaping, which is commonly used by e-cigarette users to describe the practice rather than smoking. While we don't have any specific information for Northern Ireland, the latest available intelligence suggests that there are around 2.1 million users of these products in the UK. It's also estimated from a study in 2012 that some 7% of European citizens aged 15 years and over had tried e-cigarettes. A study carried out by the University of California in January of this year found that there were over 466 brands available for sale online and over 7,000 unique flavours. E-cigarettes are a rapidly evolving global market which the multinational tobacco companies have now entered. At present, that market is unregulated. Therefore, the quality and safety of the products on the market cannot be verified. We do know, however, that the release of nicotine and the amount of nicotine present can vary from batch to batch. Also, as e-cigarettes are relatively new products, it has not been possible to determine whether the vapour inhaled into the lungs of users will cause damage to the organs in the long term. The same applies to the impact of second-hand vapour exhaled by the user. A recent report by the World Health Organization considered the emerging evidence on the health risks associated with NCPs. It concluded that there is sufficient evidence to caution children and young people against using these products. Nicotine is itself a highly addictive substance, and adolescent nicotine exposure is known to have long-term adverse consequences for brain development. In terms of the toxicity levels of the refill liquid itself, I am aware of at least 2 incidents to date where children in Northern Ireland have ingested the liquid, which has led to emergency medical treatment being required. Ingestion of a sufficient quantity of nicotine can be lethal. Overall, the World Health Organization recommended that retailers should be prohibited from selling NCPs to minors. However, for the sake of balance, I would point out that it is most likely that vaping produces lower exposure to toxicants than is the case for tobacco smoking. While the e-cigarette industry is currently unregulated, this position is shortly to change. From May 2016, the new EU Tobacco Products Directive will require all NCPs which contain less than 20 milligrams per mil of nicotine to be regulated as consumer products. The practical implications of the directive for manufacturers include the following. Nicotine levels will be restricted to below that level of 20 milligrams per mil. Products will be required to be child and tamper-proof. Health warnings will appear on packaging. There would be restrictions on advertising and sponsorship, and manufacturers will be required to provide information on the ingredients contained within products and emissions resulting from their use. Application to the Medicines and Healthcare Products Regulatory Agency, MHRA, for medicines licensing is an option for those manufacturers wanting to promote their product as a smoking cessation aid or wanting to sell products which contain more than 20 milligrams per ml of nicotine. Currently, there are no age restrictions applied to the sale of e-cigarettes and no requirement in the EU directive for Member States to introduce such restrictions. In addition to concerns that the availability and promotion of e-cigarettes is reversing progress made by smoke-free legislation to denormalise smoking, there is also a risk that they could cause nicotine addiction in young people and act as a gateway into tobacco smoking. The tobacco industry's expansion into the e-cigarette market only reinforces these concerns. In order to address concerns around youth access to e-cigarettes, a government amendment was included in the Children and Families Act to provide England and Wales with regulation-making powers to restrict the sale of NCPs, including e-cigarettes, to persons over the age of 18. Northern Ireland was not included in this amendment as the timetable for the passage of the associated bill through Parliament did not allow for the necessary Executive, Committee and Assembly approvals to be obtained. In Scotland, officials have advised that a policy decision will be made in due course. In the Republic of Ireland, consideration is also being given to legislation to allow for restrictions on the age of sale for NCPs. Following the decision by England and Wales to include powers to restrict the sale of NCPs in the Children and Families Act, the agreement of the Northern Ireland Executive was obtained for the inclusion of relevant provisions for Northern Ireland in the draft Health Miscellaneous Provisions Bill. Part 1 of the draft bill contains provisions which will enable the Department to make regulations prohibiting the sale of NCPs to minors. A provision to allow the Department to create an offence in relation to the proxy purchasing of these products is also included. It is not intended that the legislation will apply to licensed nicotine replacement therapy products currently on the market as aids to smoking cessation. The majority of these products are sold as general sales list medicines available in pharmacies and supermarkets to persons aged 12 years and over. In order to exempt existing nicotine replacement therapy products, the regulation-making powers will allow the Department to apply the age of sale restrictions either to all nicotine products of a specified kind, or nicotine products subject to specified exceptions. Schedule 1 to the draft bill amends the Tobacco Retailers Northern Ireland Act 2014 to allow for offences in relation to the underage sale of NCPs to be included as an offence, which could lead to an application for a restricted sale order or restricted premises order. In practice, this will mean that if a retailer commits an underage sales offence in relation to an NCP, the enforcement officer can include this as one of 3 offences that could result in a retailer being banned from selling tobacco and/or nicotine-containing products for a period of up to 3 years. The consultation exercise on the draft Health Miscellaneous Provisions Bill commenced on the 1st of November and will conclude on the 1st of September and will conclude on the 21st of November. The provisions in Part 2 of the draft bill relate to technical amendments to the Health Miscellaneous Provisions Act NI 2008, and it is my understanding that relevant officials from the Department will brief the committee on these provisions in the coming weeks. Dependent on the consultation responses, the Department will aim to finalise the bill and seek ministerial and executive agreement to introduce it into the Assembly by February 2015. Thank you again for this opportunity to discuss the proposed provisions with you at this early stage. Your views and any questions that you may have will be most welcome.
Okay, thank you for that. And I'm sure we would all agree that it's important to get this legislation right when we see the impact, I suppose, particularly on children and young people. And I think this committee, we're all too well aware around not only the Tobacco Retailers Bill, but the debate around standardised packaging, of the impact that, unfortunately, these products have in relation to becoming addicted to nicotine at whatever level in life. So I think it's important to get that right. But equally, I'm asking, are you aware that, for example, the Chest, Heart and Stroke group, they had requested that the bill be widened to look at the whole issue about banning smoking in cars that carry children? Are you aware of that?
I'll take that. Yes, we are aware, and we're aware that other health charities have been lobbying recently again for movement to be made on banning smoking in cars with children. What we are doing, we will intend to brief the Minister this week on the issue in response to the calls from the charities. As you know, we had executive approval back in December 2012 to go ahead with consultation on the policy around banning smoking in cars, due to the fact that a lot of the other tobacco control measures arose around the same time. They were prioritised over 2013 and the first half of this year. So we focused on standardised packaging, the Tobacco Products Directive and the Tobacco Retailers Act. But we'll be briefing the Minister this week, and we would expect the Minister then to give a clear direction on where we would go with banning smoking in cars then shortly thereafter.
Okay, so what I'm hearing, that at this point it's not ruled in or ruled out?
No, it's back on the horizon again,
Okay.
in terms of the Minister giving some thought to where we would go.
So I'm assuming if it was the Minister's agreement or view that the bill could be extended to include an amendment that would include a ban on smoking in cars carrying children, would the department then consider taking that out to public consultation, or how would that happen?
Well, there are options. I mean, we could go out to public consultation on the policy issue, or I think it's possible we could include, if the Minister decides we should go forward, we can include an amendment to the Miscellaneous Health Bill, including powers, enabling powers to develop regulations on banning smoking in cars, and then we could consult on draft regulations. So we have options at this stage, and I suppose a lot would depend on the timetable for the bill, because obviously we would need a legislative vehicle to take forward the ban.
Okay, well, can I ask then, and going forward, that the committee are kept informed, particularly of the view, the ministerial view, in relation to the suggested amendment to the bill, that's shared with the committee as soon as it's available?
Certainly we can do that, yes, Chair.
Thank you. I have a number of members that indicated. Mickey, for...
Yeah, thanks very much. The presentation is very informative. You probably answered my question, or one of them. In terms of the amount of nicotine in these e-cigarettes, one of the things I've noticed more recently is a real proliferation of them. You know, you see them virtually everywhere now, where previously they've been relatively rare. It's the amount you were saying that could be fatal if too much was ingested, particularly by children. So the 20 milligrams, is that not a fatal? Presumably that's not restricted in that sense.
Indeed, although it will be the total quantity in the container that would be at issue. At the moment, we don't know what the contents are because it's not regulated. So there's a great deal of uncertainty.
There's a need for regulation.
There is a real need for regulation to know what the actual quantity is in the container.
The other issue around the smoking in cars, because there was a debate in the Assembly probably a couple of years ago now, one of the things that struck me, and the scientific evidence, was that if somebody smokes a cigarette in a car, the toxins remain for at least an hour. So even if the person stops smoking and children get into the car, they're still inhaling all the stuff that would most affect them. And I think from that point of view, it's more of an education process and common sense for parents, because it'd be difficult to enforce. You know, how could you really enforce the, you know, the PSNI or whoever might be tasked with that duty? It'd be quite difficult, I would imagine, to enforce, you know, if somebody's smoking in a car.
Certainly, I think there would be difficulties around enforcement. We know that in California, the police do enforce similar legislation, and would be known to stop cars. Obviously, the age of the child would have to be proven before any prosecution could take place. But There is, you're quite right, there is that educational element and the deterrent element as well, if legislation was to be passed on banning smoking in cars.
Okay, thank you.
Thank you, Maggie. Paula?
Thank you. Can I just get one thing clarified when we're talking about banning smoking in cars? Is that banning smoking in cars, period, or with children in the car?
Declaring an interest here?
Yeah. I have made it known. I made it known in the Assembly as well. I'm a smoker, and I absolutely, wish I'd never. It's horrible. It's disgusting. But whenever we're talking, so I just want to ask: are we talking about banning smoking cars, period, or with children?
No, we're really looking at banning smoking in cars.
The request
Okay,
is
that's
carrying
fine.
children.
Just want to clear that one up. That's okay. So it is. I know I have a lot of friends who use e-cigarettes. I've bought one myself. I personally didn't like it, but I have a lot of people that do use it, and they have come off. They have stopped smoking, albeit they're still getting nicotine into their system from this. I was going to ask you the question about this this application for MHRA. So obviously nobody has applied for that.
Yeah,
because
well, we're aware of at least 2 companies who've applied. One company was actually granted a licence just there a couple of weeks ago for, it's not exactly an e-cigarette, it's more sort of similar to an inhalator product, but it is a novel nicotine-containing product. It's not a nicotine replacement therapy product.
There is already inhalators.
Yes.
that you can buy in
So
the
it's not
chemist.
really a first in that way, but it is a novel product, I suppose, as opposed to nicotine replacement therapy.
Okay.
It has already been granted, and they're expecting to grant, I think, the first e-cigarette licence within the next few months.
Okay.
So we'll sort of keep you updated about that, but there have been 2 applications to MHRA to date.
Okay, well, with that information then, I know one of our local radio stations in Northern Ireland frequently advertises on how good e-cigarettes are. What way is that going to work as well? If we don't allow advertising of nicotine products in Northern Ireland, so
Tobacco
is that...
Products Directive, which will have to be implemented by all member states by 2016, will place restrictions on advertising and sponsorship of e-cigarettes from that date. So I suppose until then, they can advertise.
Yeah, and I don't know if anybody's heard it. I've heard it many times. I only listen to 2 radio stations. One plays adverts and one doesn't, and it's the one that doesn't, and and it makes them sound extremely appealing, especially to young people. And I would be the biggest protester there is when it comes to young people being encouraged to take up this disgusting, filthy habit. And I wouldn't. We don't know what's in these. And from that advertising, if I was a young person, I'd think, yeah, that sounds really cool. Yeah, I think I might get one of those. So I think we need to look at that as well around the advertising, because it's being advertised now.
Well, certainly when the directive comes into force, there will be restrictions on advertising, and that's around 2016. Those restrictions will be around targeting, prohibiting advertising that targets young people, and also making claims for example, cessation or health claims. If it's not a licensed product, then the manufacturer cannot make those sort of claims when that legislation comes into place.
Okay, thank you, Paul. Roy?
2016 for this advertising ban, that's 2 years away. Is there nothing that can be done to implement such a ban sooner? That's you're relying on the EU to do it. Can we not do something ourselves?
Part of the aims of the Tobacco Products Directive are to harmonise legislation relating to e-cigarettes across Europe, and that was one of the sort of fundamental planks that was in place to get all member states signed up to the directive, and it's about harmonisation of trade, harmonisation of laws. So I would say, in light of that, there would probably be a little opportunity for member states to go ahead before that and introduce their own advertising restrictions.
Miscellaneous bill, would that not present such an opportunity, or is it something that's actually determined at a Westminster level?
Well, in terms of the EU legislation, that's UK-wide, and in terms of the member state.
Now, my question is about ourselves trying to take action in advance of 2016.
There could, in theory, be challenges to such a move by a part of a member state to sort of break ranks and to go ahead with their own legislation.
Seems crazy.
And in terms of if there were challenges, those challenges would hold up the passage of any legislation, and you would probably end up back in 2016 anyway.
Okay. I'm glad you've clarified earlier that the ban you're looking for is smoking in cars with children. I think that it needs to be at a balanced level, or there's dangers in going too far and perhaps not being as successful as you would wish. But in terms of taking that forward, just for clarification, clearly that can be carried in and amending this existing miscellaneous bill, correct?
Yes, we understand, yes.
I would say to the committee, if the department decides not to take it forward, I think we as a committee should be considering our own amendment.
Okay. Thank you for that, Roy.
So I don't know what the view of the rest of the committee is.
Well, I mean,
need to do something formally on it.
I mean, I think we can discuss that, but I think it would be important that we get back from the ministerial direction on this and the department's direction, but I think it's something we should certainly consider.
Okay.
Thank you. Kieran, next.
Yeah, Chair, just to welcome what you're doing and welcome and appreciate Paula's openness and honesty. It's great to see an honest politician, and to give him some encouragement. I mean, I was something similar a number of years ago, and I did not think I could give up the smoking, but I did. So if I can do it, you do it. So stick with it. Anyway, I just wanted to ask: is there any danger that this legislation will overtake or crowd out the very important mental capacity legislation that you're working on? The Joint Justice and Health Mental Capacity Bill.
There have been a number of issues raised about the use of e-cigarettes in, for example, hospital premises. And I know there was an exception brought to that because there was concern that any outright ban on the use of e-cigarettes on health and social care premises might have a potentially adverse impact on people attending mental health services, who, as you all know, people with mental health conditions tend to have a higher prevalence of smoking. So an exception was made then for mental health premises in terms of the outright ban on the use of e-cigarettes on mental health premises.
Yeah, but what I'm saying is the work that you're engaged in now will not push the mental capacity bill beyond this Assembly mandate. No.
I mean, I think that I hear the point, and obviously that's a critically important piece of legislation, but it's completely separate, and it's something that the committee would...
Yeah, it's a completely separate resource within the department that is working on the mental health.
And also, Kieran, I mean, you're right to raise it, but there is a letter coming through in the correspondence, just updating on it, so we need to keep tracking that as part of our role.
Thank you,
thanks. Joanne.
Thank you, Chair. Apologies for missing your briefing. So my question may already have been covered. I'm sure you're aware that in certain cases the PSNI has used the Substance Act to curb the sale of e-cigarettes, and but this is sporadic, and legislation would need to make a real impact. So have you liaised with the PSNI when bringing forward this legislation?
We would see the enforcement of the legislation has been a responsibility of district councils as opposed to the PSNI, and that would be in keeping with age of sale legislation around tobacco. As I say, the PSNI would be involved, for example, with illicit tobacco, but not in terms of age of sale, and similarly the age of sale for e-cigarettes, the enforcement would fall down to the environmental health officers within the various councils, and we have been engaging with the councils on that particular issue.
But not the PSNI?
Not the PSNI.
I know with meetings I have had on various issues with the PSNI, they have outlined their concerns with, I don't know a lot, I've never smoked, so I don't know a lot about e-cigarettes, but is the fluid that can be used by, teenagers or whatever for...
There is a danger if the fluid is ingested, it can be lethal.
Yeah.
And I think as well, I mean, it really is up to organisations like the PSNI to respond to the consultation, as opposed to the department going out and, I would have thought, because this is currently out for consultation, so I think...
Have they responded then?
We haven't heard anything, and we weren't aware that there were any issues around the PSNI and the use of e-cigarettes, so they haven't been in contact with us at all about
Have other members encountered this, Chair, with meetings with the PSNI? No?
Yeah.
No?
I mean, at the minute, e-cigarettes, obviously, you know, there aren't any age restrictions on them legally. Some of the manufacturers themselves would impose and say the product is only suitable for use for a person over 18, but that's obviously not a legal requirement at the minute, so that's what we're trying to bring in now. But at the minute, obviously, a person who is 16 is legally entitled to go in and buy.
It's something that they've raised, has been raised with me in meetings, so I just wondered, is there that link or correlation? I appreciate councils will be enforcing that, so they haven't responded to consultation and you've had no...
Not as yet, no.
Okay.
Is it on the same issue?
Yeah, it is. It seemed then this is going to fall under then the tobacco retailers bill that when I was here a year ago in Health Committee, it's the council said it's there. Yeah. So it's going to be the same. It'll fall under the same.
Yes, the tobacco retailer bill will be amended to include provisions about this and similar sanctions.
So it's council are responsible there for the
Okay, Joanna, are you okay with that?
Yes, it's just it's something that they've raised with me in meetings, and I thought maybe it should be feeding into the consultation or whatever. So.
Well, the consultation doesn't close till 21st of November, so obviously there's still time. It only went out a few weeks ago, so hopefully we will hear something from
You must raise it with them at the next meeting.
They possibly have they maybe were aware of the incidents where the two young people up in the northwest ingested liquid and possibly were called out to that scene, and that maybe generated their interest in the issue.
Okay, thank you for that. I mean, you've heard the views of the committee, and it's critically important to get this right. I think it would be very useful, as soon as practically possible, to share the view in relation to the proposed added clause or the amendment to the bill, if that's a possibility. So we would look forward to that response and hopefully the foreseeable future.
We will certainly let you know as soon as possible.
Okay, thank you.
Thank you very much.
That. Okay, members, moving on. The provision of health services to persons not ordinarily resident, regulations 2014, and the health and personal social services amendment number 1 regulations. It's page 102 of your meeting folder. Includes information on the department's revised proposals for the regulations and a response from the Law Centre advising the department has consulted with it and it is content with the revised proposals. There is a copy of the revised draft regulations which can be found at page 129 of the table folder. This has been an important piece of work. I think that the committee has been to the front on. I would advise members at this stage that in terms of the process, the next stage is for us to take a decision on whether we're content to proceed with the proposed statutory rule. I'm asking members if they're now content that the department makes the statutory rule. Agreed.
Yep, agreed.
If we just comment, the Law Centre obviously were instrumental in advising us on some of the stuff, and they seem fairly content at the moment.
Yeah.
I think the issue, is as long as the department will consider, continue to liaise with us in terms of the guidance, because while this is a legislation, the guidance can be very, very important.
No, absolutely, and I think again there's been a good piece of work, and I think in fairness the department have moved to address the concerns that was raised here, and yes, the Law Centre have indicated that they're content with the process to date, and I'm sure that they will continue their lobby as the guidance is worked up. So, members content to proceed?
Yep, great.
Thank you. Okay, members, item 8 is the Health and Personal Social Services. Health and Social Care Amendment number 2 regulations is page 115 of your papers. Can you just say Paula Bradley has declared or will declare an interest?
Sorry, yes, I declared interest.
Okay, thank you. And the committee did consider and approve the SL1 for this rule at our meeting on the 24th of September 2014. Are members in content?
Great.
Okay, I'll put the motion. The Committee for Health, Social Services and Public Safety has considered the Health and Personal Social Services Superannuation Health and Social Care Pension Scheme Amendment number 2 Regulations 2014 and has no objection to the rule, subject to the report of the Examiner of Statutory Rules.
Great.
Members, item 9 is the review of the Department's Benefits Management Framework for Transforming Your Care. I just want to refer members to page 155 of the tabled folder today for the relevant papers, including a response from the Department providing an update on the outcomes framework for TYC Just again, reminding members that the committee agreed on the 17th of September 2014 to consider the appointment of an expert advisor to assist us in scrutinising the department's benefits management approach to transforming your care, a key piece of work that had been identified as one of our priority work pieces and going forward, specifically looking at whether this benefits and outcomes framework has the capacity to actually measure changes to the level of health inequalities and to examine alternative approaches. So I'm advising members that although this item was considered during the informal sessions, decisions now need to be taken on taking the review forward. We need to agree that formally today in public session. So I'm asking members to just maybe consider the preferred option for the selection of an expert advisor. There were some conversations around the composition of a subgroup, around the potential of the chair and vice chair overseeing that process. Could I ask our members in agreement with that?
Absolutely.
Okay. The number and breakdown of days required for the expert advisor, I'm looking to Marie for this. We had talked about 7 days. Are members in agreement with that?
Great.
And the terms of reference for the review, equally in your paperwork? Is there anything specific or?
At paragraph 12.
Okay, I'm taking it that that's fine as well, thank you. And also the methodology for the review?
Paragraph 14 and 15.
I think it's fairly straightforward as well, yeah, okay, thank you, Marie, for that. Advising members that following a request by the committee, the department has provided that update on the outcomes framework for transforming your care. During the summer, the department developed a list of metrics, qualitative measures to demonstrate progress against the various outcomes. These qualitative measures are undergoing final validation before being discussed and approved at the next transformational board meeting, which is on the 31st of October. So I'm seeking agreement from members to request an update following that meeting, including the details of the measures approved.
Great.
Thank you. Item 10, members, is a committee review of the departmental approach to the budget 2015-16, another key priority that was identified by the committee. It's on page 131. Reminding members that the committee again agreed that the scrutiny of the budget 15-16 would be one of our strategic priorities going forward. Advising members that although again this item was considered during the informal session, I do need to take decisions today formally on that. The first step would be to agree the terms of reference, which are at page 133. I would suggest members just one amendment to that in relation to the first terms of reference, I would be suggesting that the reference to transforming your care should read to assess the department's approach to budget 2015-16 in terms of whether it is based on a clear understanding of how implementation of transforming your care relates to spending decisions.
Yeah.
It's anyway, I think it's just more wording than anything, but if members are comfortable with that. Are there any other comments on the terms of reference?
Chair, I mean, you just mentioned there, what about ensuring that there are adequate resources for the transforming care? And that goes without saying. But the other one is exploring the full potential around prevention, public health and early intervention. Would that be, well, is that involved in the terms of reference?
Well, I think some of that will be, I suppose, examined in the course of the piece of work. Because part of the piece of work is to scrutinise the budget going forward and then to look at where alongside of that will bring up where the priorities are in relation to budget. So I think those conversations will take place as the process goes on.
Fair enough.
Okay, so I'm asking members then to agree the terms of reference that we alluded to for the review,
Great.
the methodology for the review, and again the timetable.
Great.
Okay, item 11, members, is the forward work programme. There's a revised forward work programme for the period October to December, page 135. of your meeting folder. I'm asking members, I don't think there's anything too different in that are they content? Are you content with the forward work programme?
Yep. Great.
Thank you. Item 12 is matters arising. Informing members of 3 items under matters arising. Item 12.1 on page 141 is correspondence from the previous minister providing a breakdown of the 11.4 million which was shifted from 2012-13 from hospital-based services to community-based services. Members note from the correspondence that all of the money shifted related to resettlements in the fields of mental health and learning disabilities. So there's no information in the correspondence in terms of a shift of the acute programme of care. So I'm therefore suggesting, members, that we write back to the department and ask them when the figures for the money shifted during 13-14 will be available, and to request a copy of the breakdown of those figures.
Yeah, great. Okay. I mean, you mentioned the resettlement. Again, one of the outcomes of this funding request that we've heard about, there is a shortfall there. I forget what it is, 1.1 million. And if that is not forthcoming, there's going to be a stoppage on the resettlement. And the resettlement was for to be completed by 2015. And if that funding is not forthcoming, we don't know, it probably might not be, does that extend the resettlement period? Something that we should be making inquiries about.
Okay, thank you.
I'm thinking particularly there's a Muckamore here.
Yeah, and I think we have also as a breakdown per trust area, which I'm sure individual MLAs will reflect on in terms of their own constituency work. And then there is the wider shift left, and we don't get any indication of that in this correspondence. So that's what we need to try and interrogate here. Item 12.2 on page 143 is correspondence, and I know, Kieran, you had raised this from the previous minister, providing an update on the timetable for the mental capacity bill.
Yes.
I and with some other members attended the all-party group on mental health yesterday. There's been, I think, something in the region of 118 responses to date, including one bank, which I think is interesting in itself. The responses to the public consultation are currently being analysed, and the department hopes to be able to brief the ad hoc committee in November. This is the timeline we've been given here. We had obviously, where I had raised concerns about staffing capacity in the Bill's office regarding the drafting of the bill, but the department appear in this correspondence to be on track in terms of the timetable. So I'm asking members now, are you content to note that response and going forward?
Great.
Also, page 163 of the table folder is a response from the Minister regarding the North West Health Innovation Corridor. Just for the record, I intend to go back in relation to having listened again to the evidence that was given from the department and go back and clarify some of the comments that was made from the department in relation to this important piece of work. So I'm asking members, are you content to note that at this stage?
Great.
Under correspondence, I have 7 items of correspondence and 2 separate items in the tabled papers. So again, in the interest of time, members, I am just going to draw your attention to several of the items. Paula, yes?
No, I just wanted...
Okay.
Yeah,
sure.
One of them.
Page 145 is correspondence from the Minister regarding consultation on the proposed changes to the regulations that underpin the pharmaceutical price regulation scheme. Much debate about this currently. I'm suggesting, members, that we go back to the department to seek clarification. We have been informed that there has been a revised scheme which was in place from the 1st of January 2014. We've now been given the figure of 2.89 million that was brought back into the system by dint of the first quarter. So I'm suggesting we go back to the department to clarify how this relates to the new scheme that came into force in January 14, or how is it different? Okay. 148 is correspondence from Mr. Dominic Bradley, asking that the committee tables an all-party motion calling for the Minister to adopt the Canadian consensus guidelines for the accurate diagnosis of ME. I'm suggesting, members, that the committee, really hasn't considered what the Canadian consensus guidelines are, and I know that members are very supportive of the campaign around ME and have been part of the conversations here, but I'm seeking agreement that we write back to Mr Bradley advising him that it wouldn't be appropriate for the committee to take the motion and that he should contact the business office regarding tabling it as a private member's motion and getting it co-signed from members as within their right from other parties. Are members in agreement with that? Thank you. 13.5 on 153 is the new Assembly EU Matters monthly newsletter, asking members to advise the clerk if they have any views on the content format of the newsletter, and I think that can be an ongoing piece of work. Or do you need views? Or?
No, Chair, it's just a new thing that has been produced by the EU coordinator in post. It's really just to seek, this is going before all committees, seeking views on the format, just a bit of feedback really on how useful members find it.
Okay, so can I suggest to members if they want to feedback to Catherine on this? Do so, okay. Page 160 of the meeting folder and item 13.9 on page 167 of the tabled folders are requests from Guide Dogs NI and Pro Paramedics to attend the committee stakeholders event on the 8th of October. Again, just asking our members content to invite the groups.
Absolutely.
Thank you. And therefore I'm seeking, Paula. Yes.
Can I just bring up page 147, the consultation on the proposal to remove the ban on the sale of HIV self-testing kits. And can I just say I welcome that consultation. I chair the APG here in the Assembly on Sexual Health, and we know the pressures, we know ourselves, the pressures that are placed on our own clinic, our own GU clinic here, and also on Positive Life. But it's more than that. It very much is, it's going to capture those people who are afraid to go to their local clinics, their local GPs, whatever it might be, for that referral on. So it's very welcome. We already have in our system test kits that you can buy across the counter in chemists for a vast range of sexual health matters. So this is very good, and it's good. I note at the bottom of that, which is probably one of the best bits about it. You know that a positive result of HIV from self-testing must be confirmed by a health professional in a clinical setting. So that alleviates a lot of fears that people just are able to send these in and get the results, and it goes no further. You know, so that's very positive and very welcome.
It is welcome indeed. Thank you, Paula, for that.
Chair, before you leave, page 158, the request from this chap, John Doherty, could we fit him in under the 8th of October or a future stakeholders event?
I would say, and I'm happy to pick this up afterwards, but I do think that the gentleman concerned here isn't actually representing an organisation or a group. So therefore, in terms of stakeholders engagement, it would be difficult to justify that. We have, as a committee now, already written to the Minister on Mr Doherty's behalf, and we have forwarded him the detailed response. Absolutely no issue if individual members wish to further engage with Mr Doherty on his issues. They're absolutely free to do so, but it's not within the remit of the committee as a committee to deal with that.
But simply because he's an individual rather than a representative?
Yeah, I think what it is within the correspondence as well is that there's individual cases being raised, so it's not a remit that the committee can get involved in.
Will you relay that back to this guy?
No, I think we have done what we can do to this date. We have raised it with the Minister and forwarded the detailed response. I think, again, just to stress, Kieran, I think if individual MLAs want to engage directly with this gentleman, fine. That's completely within their gift to do so. Okay, members, item 14 is any other business. Roy?
Just looking at the forthcoming order papers, this would appear to be my last meeting with the committee. So I just wish to thank the staff for their assistance whilst I've been on the committee, and thank the members and the chair for the courteous manner which I think we've worked together, and wish you well for the future.
Well, can I just say, Roy, because I wasn't aware of that, maybe people say you should have read your papers for next week quicker, but can I wish you every success, and it has been a very useful engagement. I do think that this committee has worked well, and I think you've played your role to all of your potential. I think that's to be welcomed, and wish you every success in whatever committee you go forward on. So thank you.
Here, here. Chair, just before we go, I mentioned it earlier on about the chaos in the A&Es. Should we, the committee, write a letter to?
We have just last week written off in relation to the updates specifically in the Royal within the last 10 days, and we are waiting for an update from the department in terms of the review of on-schedule care, and I would be thinking that we would have the department in specifically on those issues as that review develops.
Yeah, because
so
you know
I think
the
we have a letter.
chaos.
We have a letter written off to them.
The chaos in the Ulster yesterday, I think it was yesterday and the day before, where they just simply closed down to
Well, what I'm going to suggest, and I know what you're saying, there is a letter that's went off to them in relation to the Royal. I mean, it won't be taken seriously if we're writing off every week. I think as the unscheduled care review gets established better, when we have an evidence session on that, we can tease out all of those issues at that point. Okay, members, your date, time and place of next meeting is Wednesday the 15th of October at 2 o'clock in the Senate. Just remind members again that the stakeholder event will take place next week at 2 p.m. in the Long Gallery. There will be a pre-meeting at 1:30 in the Long Gallery, and lunch will be provided. Thank you.
Northern Ireland Assembly, Committee Room 29.